started. If we can kind of settle down. Morning. Welcome. Yes, everybody say morning back so you know you're woken up. So it's such a pleasure to see everybody, and I know people are probably still kind of trilling in, but I'm going to go ahead and get us started. For those of, I think everybody knows, I'm Michelle Stevens, and I'm going to do a little introduction of myself, and Anna will do a little introduction of herself when she comes up. We are the two PIs of the Black Bodies, Black Health grant, which is, of course, funded by the Robert Johnson Foundation, and we have our program officer here, Claire Gibbons, who is the first person that I want to thank for allowing us this really exciting intellectual opportunity. And so I'm going to just start off by, I should tell you a little bit about myself. I am a professor in English and Latino and Caribbean Studies here at Rutgers, New Brunswick. So I am one of the humanists in the room. There are others. I am also the founding and executive director of the Institute for the Study of Global Racial Justice. And the Institute itself, which you'll hear more about as we do our talk, but it is also very invested in kind of creating an interdisciplinary space for scholars from different fields to come together. So the Black Bodies, Black Health Project has been a really wonderful opportunity for us as an institute, and so we're really happy that to kind of be here in person with it, right? We've been doing everything so far virtually, so it's wonderful to see you all in person. So that's who I am. I want to give some thanks because this event so far is actually the successful product of a number of different people. So of course the first person again that I want to thank is the Robert Johnson Foundation and Claire for helping to sponsor this event. The second groupings that I want to thank, I won't list you by name because you're also, there's a lot of you, but our external experts, thank you so much for giving of your time and your intellectual labor and generosity. I know Anna and I appreciate it. I know all of the seed grantees appreciate it. So, and we know kind of coming in person can be a thing. I hope this feels like it was worth it. We felt that it was definitely important to have us all here engaging in person. So thank you so much for giving of your time. Our seed grantees and our steering committee members, also thank you. This project wouldn't be possible without you because you're the ones doing the actual foundational work on which this is based. And so we want to thank you for being a part of this and kind of joining the group. And of course, the steering committee that has been offering Anna and I really great guidance and help in just thinking about how to structure this and set this up. And we'll continue to do that as we think about the project going forward. So really appreciative of your collaboration. The next group that I want to thank is, of course, the leaders and the staff at both the Eldridge Hotel, which is, of course, hosting us and has done such a wonderful job in facilitating our conference. And then later on this evening, also the team and the leadership team and the staff of the Rutgers Club, which will be hosting our keynote event later on this evening. Then, of course, this wouldn't be possible without two other groups and an individual. So Rob Posner and his team from Pro Innovations, who is doing all of the videography and live streaming, all of the kind of videographic work for the conference. Really want to thank them. The gentleman in the back, thank you so much for your support. And then similarly, Joe Watkins from Sketch Effect, who is actually going to be shadowing and recording our conversation in our series of conversations over the day in an innovative, illustrative form. And so that, I think, is going to be fascinating for us to watch as that develops. And thank you again so much for joining us. Last but certainly not least, this is something that I was chatting with, I think it was Maxine about yesterday. The Institute and Anna and I with this project are firm believers that intelligence and brilliance is not enough for superb scholarship. Creating communities of care is also as important, right? And I think many of us are very aware of that, right? And so I have to thank my team and the team that is the kind of staffing team for Black Bodies, Black Health itself. And so I'm going to name them out. They have been the people behind the scenes trying to take care of all of us in the lead up to this, and of course during the conference itself. So there's Desiree Manning, our program coordinator, who isn't in the room because she's still manning the desk right outside. There's Robin Yarbrough, our business manager, who's right here in the corner hovering, just making sure everything is okay. There's Candace King, our research and project director, who is also, I think, here both as attendee, but also kind of keeping an eye on what's going on. And there's Tanya Bentley, who isn't here, but she's our director of communications, and she's got all kinds of automatic, things set up to go. So things that you're receiving from her virtually, even though she's not physically here and on vacation. So I really want to thank them for their support. So okay, so that said, let me turn things over to my partner, Anna Branch, and she'll pick up from here.
Thank you, Michelle. Morning, everybody. So this has been, this project, moving it from vision to execution, has been so much fun. We cannot tell you, speaking for myself and Michelle, how fun and rich the conversations have been, starting with yesterday, seeing the vision for why an interdisciplinary conversation matters kind of come to life, and hearing all of you kind of react and engage has been wonderful. So today we're going to go a bit deeper. The conversation is going to look a little different, and we're kicking it off. My name is Anna Branch. If you see it written, you'll see a no-bung Hannah Branch. It's the same person. I am the Senior Vice President for Equity here at Rutgers and a Professor of Sociology at Rutgers, New Brunswick. And this conversation, this project, Black Bodies, Black Health, Imagining a Just Racial Future, is kind of an idea that Michelle and I had because I'm a sociologist and she's a humanist. And for both of us, we talk about things in related but very different ways. And so another project that I was on a couple of years ago touched on a related theme, and there's just such value and such richness. And so for us, what would it look like to bring a set of scholars together? So you're joining in our conversation, and we want to give you some background. Why does centering the Black body matter? Because if we're going to talk about racial disparities, we could talk about a lot of things, and we can start in a lot of places. For us, centering the Black body is where we begin. And so I want to start from a very particular place. So hypervisibility and invisibility as kind of a conversational front. Last December, this medical illustration of a Black fetus went viral, spawning multiple news articles and fascinating public discussions across social media as doctors and the public alike reflected in awe at the rarity of the sight. The reaction was due in part to the normalization of whiteness, even at the indiscriminate level of an image. One doctor created a Twitter poll asking others, have you ever seen a dark-skinned baby inside a pregnant mother, illustrated in a medical text? 96% of the nearly 4,000 plus respondents said no. And this was not an aberration limited to that Twitter cycle. I want you to meet the article, the student at the time, now a medical student, who was doing this work, Chidebere. Less than 4%, the article highlighted by NBC News highlighted just 4.5% of images. In general, medicine textbooks show dark skin. And this was done by researchers at the University of Pennsylvania. This base level of representation, or more accurately, the lack thereof, has implications for who and what we see as normative, who's characterized as well and unwell, and which bodies we value, and which bodies, we don't. Continuing along this theme of hypervisibility and invisibility, the same thread, a conversation began. And one Twitter commentator noted the anatomy slides and says, even in anatomy diagrams, they said, they'll literally rather make the person blue. The conversation continues. Most modern medicine doesn't consider anything but white men's anatomy and physiology, even today. It's structural racism that's so baked into the systems that often not even the people embedded in them realize the harm they're propagating. So this is public conversation, December 2020. We're not at December 22 yet, but in December 2020, this was the public conversation, right? Hypervisibility and invisibility. The concept for this page, and if you've been to our website, you've seen this feature, please visit and learn more, was to center humanistic and social scientific fields to identify strategies needed to disrupt structural racism as a determinant of health and well-being. We wanted to help and partner with the Robert Wood Johnson Foundation to understand how do we come to a point where white bodies are naturalized and Black bodies are invisible. What are the consequences of representation? And what can the Robert Wood Johnson do, kind of learning from and building on our research to create a different and more just future? So that's the ideal. To start with that, we wanted to center in the conversation the notion of Black bodies as a site of disorder. And so here, drawing on the idea of a cultural imagination, In the cultural imagination of disease, the Black and minority body is seen as that site of disorder. And the representation of Black bodies as being unwell has consequences for how systems and structures engage and respond to their disease in ways that serve to undermine their well-being. The cultural representation of disease, from news media to public commentary, influences how systems and structures respond. When the origin of the disease is culturally represented and understood in the public mind as rooted in individual and reckless behavior, resolution requires individuals taking personal responsibility. Whereas when the origin of the disease is understood to be in the mind, deviation rooted in susceptibility, it's understood culturally as a public health challenge, which requires state investment and public sympathy. Our goal in bringing together biomedical researchers, humanists, and other social scientists was to try to have all three research orientations in the conversation at the same time: the study of behaviors, the study of structures, and the conditions that are framing the way that we think about the Black body and Black health, and have an intentional and dynamic conversation. I want to give you an example of what this looks like: opioid versus crack, and the way that in conversation, Congress has been reconsidering the approach it's taken for a long time. Using the lens of those two crises, we can see how locating the crack epidemic's challenge as a problem of individual behavior rooted in recklessness led to a very different public response than the opioid crisis. The race of the user, and often white in the case of opioids, humanists and many others argue, had everything to do with what systems were mobilized and the way that they chose to respond. And so these two articles are noting 2 points. That at present, this is a 2021 article, the Biden White House is looking to undo the sentence disparity for crack versus cocaine. The second article, or the first one noted from the Wall Street Journal, is noting a different point: how part of the conversation right now in fighting opioid abuse is focused, and the emphasis is on funding research into the public health crisis, right? Very different orientations, very different roles of the state. So what does this all mean for what we understand as the role of research, and what are the gaps behind what's driving these racial disparities and the impacts on life itself, right? So we know systemic racism matters. It's much, much more of a public and clear conversation. On the individual level, the results are clear and damning, and it's increasingly understood, from shortened life expectancy to premature birth, racial discrimination kills. And in this legislative update that was done by a lobbyist group, this was their shortened summary for congressional and policymakers' consumption. And the headline I just want to note for you was Health Equity, examining how systemic racism has sickened our communities. And this is the illustration that's really short. It says African Americans are 40% more likely to die from a stroke. Asian Americans and Pacific Islanders are 58% more likely to die from liver cancer. American Indians, Alaskan Natives, 40% more likely to have heart disease. And the Latinos are much more likely, 63%, to be diabetic, and on, right? The data is clear. And so conversationally, we know that this is a reality that's shaping life and death in America. The issue is, are we reckoning with it? And so that's the conversation in part for us. This was another article recently highlighted in Healthline, where they said these are several truths that we know around why those outcomes that we saw previously happen. And so while we can acknowledge structural racism, how and the way that it functions, its impacts, are much less understood. And in the research done by many of you in the room, there's a renewed call to focus on racism, right, and abandon race, the construct, and to track and disrupt racial disparities. To not just reify differences between racial groups, but to really get into imagining and envisioning the work of disruption. And that work of disruption isn't often where health research experts begin. It is, however, the intellectual strength of the humanities and the social sciences. Fields as wide-ranging as sociology and the study of English literature have used different methods to both document and spar with the origins and depth of race as an organizing frame in American society and the world. These scholars, though, haven't been invited into the conversation to engage in discussions about the possible successful remedies and interventions for population health disparities that we would argue are grounded in age-old conceptions of race that are older than America itself. And with that, I want to turn it back to my colleague, Michelle. Thanks.
Thanks, Anna. So continuing along, so the question that then animated this project at large and Anna and my conversations was very much, so what would we learn if we actually brought humanists, social scientists, and biomedical researchers together into the same room from your disciplinary perspectives to explore, unpack, and disrupt structural racism in the service of creating equitable health outcomes? And I actually want to flag disrupt there because the idea wasn't just to bring you all together to talk, it was also with an eye towards disruption, because in a sense it motivates our thinking, right? And it motivates what we're listening to in each other or from each other, right? And so how might humanistic approaches to the call for justice, which center the redefinition of the concept of being human, right? How might that help us to foreground the ways we resist recognizing people who live under different circumstances than our own, right? So that's a particular way of thinking about what the humanistic frame does. How might that be reconciled with the lasting impact of black people's exclusion from humanity itself in pre-emancipation America, but also in different global contexts, right? So these were some of the questions that were animating. What would we learn, right? To tell you a little bit then about the kind of institutional framework for the project. This is, as I mentioned in my opening, this project is very linked to the institute itself that I direct, right? And of which Anna is a senior fellow. So the Institute for the Study of Global Racial Justice is actually a system-wide Rutgers institute. There are very few like this at Rutgers. There are some, but there are very few that move across all of the campuses, right? Our goal, our aim, our vision is to serve as a conduit for new knowledge ideas. We envision ourselves less as a monolithic entity and really more as an intellectual corridor, right? And we're hoping that we can provide opportunities for Rutgers faculty and our colleagues elsewhere in the academy whose inquiries address racism and social inequality to work collaboratively to effect meaningful action and positive change. So through Black Bodies, Black Health, we brought together this kind of cross-disciplinary group of experts to help explore and unpack structural racism in service of creating equitable health outcomes. We wanted to center humanistic and social scientific approaches, but we wanted to make sure that they were respectfully in dialogue with biomedical approaches and where everybody's starting point is, right? Trying to put them on the table in a level kind of way. So in purposefully bridging fields across Rutgers, we interact with scholars from law to English, from philosophy to public health, from history to sociology. Black Bodies, Black Health really exemplifies the purpose of the Institute, to serve as this kind of university-wide intellectual corridor. And what we're hoping is that it escalates the likelihood that our findings and our explorations can actually inform real-world decisions. It's very rare for humanities institutes to be able to get beyond the scholarly community. It's more the case with social science institutes and biomedical research institutes, right? We are really hopeful that this interdisciplinary conversation will help us to inform real-world decisions, providing solutions to problems that, of course, have been increasingly thrust into sharp focus in the United States and around the globe. So the interdisciplinary approach of Black Bodies, Black Health is exemplified in the research specialties of both the project's co-leads, myself and Anna, and of course being a sociologist, myself being a literary and cultural critic and a psychoanalyst. But the Black Bodies, Black Health steering committee also covers a range of areas of expertise, including public health, family medicine, sociology, and psychology. So I'll kind of flag people as I catch them in the room, but you'll see some of our faces here. So we have psychologist Luis Rivera, who is in the psychology department at Rutgers Newark, who's a member of the steering committee. Perry Halkaitis, who'll be joining us in the afternoon, and some of you would have seen him, met with him yesterday, who is the dean of the School of Public Health. Dawn Mouzon, who is, I saw right there, who is a sociologist and at Rutgers, New Brunswick, here in New Brunswick. Shauna Hudson, who wasn't able to be with us because she's out of town, but she's a professor and research division chief in the Department of Family Medicine and Community Health at Rutgers Robert Wood Johnson Medical School. And Carlos DeSena, who is my colleague in Latino and Caribbean Studies, cultural critic, interdisciplinary scholar, who will also be joining us this afternoon. These are the members of our steering committee. When we tried to think to ourselves about how do we see the different fields, this was our initial conception of what is it that each group of researchers might be bringing to the table, right? So we understand kind of that humanistic scholars, and this is our frame. You all will have your own frames, right? But this gives us a kind of starting point, right? So humanistic scholars tend to think about questions of the development of age-old conceptions of race that ground population health disparities. They examine histories of this way of thinking, as well as the systems that produce, reinforce, and reify this pattern of thought, right? Social scientists tend to focus often on how health disparities and differential treatment are embedded in the structures and systems of the present, highlighting how an emphasis on personal responsibility misses the systems and structures that influence and shape human behavior or differentially condition the response of the medical establishment to treat it. And then finally, both in contrast but in dialogue, a biomedical approach tends to emphasize the physiological factors, often exclusively, and then aggregates to describe patterns and disparities across groups, which has led to a focus on interventions on individual behavior and typing of racial ethnic groups as well or unwell, for example, Black women and obesity. So these are kind of some of our starting frames for thinking about where the different disciplinary locations may begin, right? The overarching principle, which was a principle both of the Institute but of the project, is to keep the humanistic element central. So one of the things that Robert Wood Johnson was particularly interested in, why we were asked to join this broader project of kind of engaging with the foundation about how they are directing their research on race and health disparities. They were interested in the humanistic orientation of the Institute. And I say humanistic on purpose because we really are envisioning that as a kind of broader frame that isn't just specific to humanities-specific disciplines, right? Even though it's very much influenced and informed by them, right? And so the way we think about Anna and I and the group as a whole, how to keep the humanistic elements central, is by, again, a set of questions. What would a just racial future require to remediate the imprints of the past in the structures of our present? What must we disrupt to achieve health equity? These meaty questions are not the purview of a single discipline. We really feel like you can't answer them from just a single discipline. They require the marriage and the purposeful intersection of fields and scholarly breadth. So we center Black bodies and Black health precisely because Blackness and the African/African American body were central to the inception of race. Therefore, they must also be central, or they must also be central to its disruption. And that's a kind of core, kind of intellectual starting point for us. So the project, in the chronology of the project, what happened is once we received the grant, one of the first things that we did after setting up our steering committee was set up a call for proposals to see, and we tried to distribute that as widely as we could across the Rutgers campuses, the Rutgers landscape, precisely to draw that mix of scholars that we were interested in drawing. And what happened was once the proposals came in and we had identified our seed grantees, there were some patterns in projects coming from very different places, but yet some interesting patterns that I think provide a little bit of a snapshot, we think, of where the conversation is, a kind of some guiding points, right? So the research clusters that you are organized into reflect these kind of guiding posts, right? So I wanted to just describe them a little bit. So we had 4. Physician education, and here we have researchers in fields as diverse, and by the way, this is another Chidiebere Ibe illustration that I wanted just to flag. But in terms of physician education, researchers are in fields as diverse as applied psychology, that's Alexandria. I won't try and flag everybody because I'll slow down trying to find everyone, but I'll just list names. Alexandra Bauer from GAZAP in New Brunswick. GAZAP is a graduate school of applied psychological studies. History, Johanna Schoen from Arts and Sciences in New Brunswick, and medicine, Pamela Brugg and Juana Colas Hutchinson from Rutgers Biomedical Health Sciences. They're examining such topics as communication between doctors and Black families in neonatal ICUs, the impact of cultural humility among physicians, and the effectivity of technological solutions to uniting like-minded patients and physicians. So these are some of the areas that they're covering. The second grouping, the carceral state, we kind of understand the carceral state to be a kind of crucial contemporary instance of the institutionalization of systemic structural racism. It's an important kind of case, right? And the institutionalization of systemic structural racism producing negative health outcomes is very much the focus of a number of the scholars in this grouping, including scholars from philosophy, Lauren Lyons, who is in philosophy in New Brunswick, psychology, Lori Hoggard, also in New Brunswick, from nursing, Anne Bakji from Rutgers Biomedical Health Sciences, and from social work, the School of Social Work, Maxine Davis. And all of them in different ways are studying the ethics of carceral justice, but also its kind of systemic instantiation. How does that link to questions around health equity? Our next group is environmental racism, our next cluster. And the researchers in this group are studying the impact of environmental racism specifically on health outcomes. And we've got researchers from the environmental sciences, such as Anita Bakshi, who's from the School of Environmental and Biological Sciences in New Brunswick, from the School of Nursing in Camden, Mei Fu and Wanda Williams, from history, Rachel Devlin, here in Arts and Sciences in New Brunswick, and each in their own way is focusing on questions of environmental justice and indigeneity, the impact of place-based versus person-based barriers on rates of breast cancer screenings among Black women, and a microhistory of the impact of environmental racism on a Southern Black community. Our last group are focused on Black bodies specifically. They're at kind of the center. And here we have researchers from applied psychology, such as Peter Economou, also from GAZAP, and his team of researchers who have joined him, and also from labor relations. Yana Rogers from the School of Management and Labor Relations in New Brunswick is the lead of that project. And they're studying racism as a contributor to physiological stress in Black athletes and in Black women in the labor market. So I went through the specifics as much to give you a sense of the projects on the table that you've all been talking about, but also to give you a sense of the disciplinary range, right? And even the clusters themselves are trying to bring different kinds of researchers into dialogue with each other. So if I had to kind of characterize the project's overall aims, I would say that both the internal, which is the workshops that we have done here at Rutgers ourselves, right? Workshops, for example, trying to establish a shared vocabulary of race. That was something that we did very early on. Workshops trying to think through what is the relationship of our projects to disruption, right? So we've had internal workshops, but also, of course, this event, which is our external workshop, really bringing what we are doing in dialogue with scholars and experts and colleagues from outside of Rutgers, right? So both include a strong systems-informed analysis of the ways the different forms of research, humanistic, historical, linguistic, and representational, social scientific, policy-oriented, using quantitative and qualitative research methodologies, could be integrated and brought together as the foundation for imagining new areas of research that span scholarly, legal, and policy arenas. This expert workshop this summer brings together thought leaders from across the country to discuss the topic areas with us that I've outlined above, both in terms of what is known, but also to help identify the research problems yet to be studied, with all with the focus of enabling the disruption of structural racism. And part of why we have this kind of background of just recording our conversations is to allow us to think very freely and to try to think kind of a bit outside the box as we're mixing languages and mixing methods and approaches and disciplines, because as I said, it's as much to identify what is known as what is new that needs to be known, right? And I think in a way that will be very helpful for the Robert Wood Johnson Foundation. So in this way, we're hoping to produce convergent knowledge, identifying themes that can inform future directions and future research directions and investments, and will likely generate new interdisciplinary research areas. Gathering together diverse, disciplinary-based scholarly communities that are all wrestling with this broader question of how to advance racial justice, we're hoping that this intervention can offer a site, a frame, maybe even a model for generating knowledge that has the potential to be transformative. So that's the charge that we're laying on all of you. We're going to pause here. It was intended to be a bit of a frame. It helps to situate the external experts. They kind of understand. Yesterday you were involved in more one-on-one and cluster conversations. Today, in a sense, we're still working those levels, but also trying to kind of move up to the macro level of the project as a whole. So this was an effort to kind of, provide that frame for you, but then also, of course, to begin to talk about some of the issues that we've raised. So we're going to pause here and then both help to just guide a conversation and discussion, reactions, responses to any of what we have been laying out so far.
Awesome. One of the things. Thank you. So one of our aims really is that you're going to get prompting talks. The goal is that the talks that you'll hear get the conversation started. But as we did yesterday, our aim is to talk with you, not just at you, right? And so I hope your brains are buzzing, that you've got comments. We're not looking, this is actually an invitation. You know that regular conference thing where say, I really have more of a comment than a question? This is that moment where we're actually inviting that comment/question. We want you to react and think with us. This is our frame, and we're very clear in owning. We were putting this together. Again, there's been fantastic conversations that began already, but this is your moment to kind of be in dialogue with us. So Candace has a mic, and she'll be coming around because we want to make sure that the voices, again, this is being live streamed, so we want to make sure that your voice is both captured and we're able to follow on. You got a question in the back, Candace? Thank you.
Okay, this is both a question and a comment, but I do need to, it's going to come out, but the question I have is around this attempt to bifurcate racism into race and racism. Mm-hmm. So the idea I have is, you know where I'm going, right?
Go for it.
So the main idea is you don't have racism until you have race. And that's one area I think we all understand. But if you go back to like the 90s, there was all this conversation around you can't get rid of racism until you stop counting race, versus you need to have race in order, right? And there were actually policy decisions. In California, there was a proposition, it failed, but 20 years later is actually, they revamped it, but it actually won. So now you can't use race in admission processes for colleges, which means you can't document whether there's racial inequities to then justify maybe in fact there actually is racism. Mm-hmm. So you always need this link to say quote unquote counting race. And I think at least some language that would be helpful to add is this question of racialism. Mm-hmm. There's racism, which is, we understand it as this inequity that is perhaps purposeful or not, but racialism is that you're counting it all. Mm-hmm. And at least in Europe, the conversation is that even racialism is racist, which is what that prior policy position. So the struggle I have when we focus on only racism, or we only focus on racialized bodies without understanding that they were racialized, that we're in some sense recreating the wheel in trying to debunk the problems that came about from what, I have to put it out there, the racial colonial capitalist endeavor of racialism. I don't see how you can, and I think for instance, this is kind of, it's not really a warning, but kind of really to health and equity scholars that the problem with bodies is it's the actual body. It's not like, economics and you can say there's my money on the table, it's not black. The body has a color to it. And regardless of what is happening, you can't talk about racial inequities until you count the body itself. And so with health inequities, refusing to count the body as itself a racialized subject perhaps is going to make it more difficult for us to use measures and constructs that can be standardized in a way that removes, frankly, European bodies as the center of what it means to be healthy, right? So there's some conversations around measurement that I'm having that are caught up in, sorry, gotta go there, the post-colonial project.
No, that's amazing, and a really important comment. And we were having this conversation yesterday, so really happy to already see the commentary kind of connection, because that's actually been a really rich part of the conversation. So thank you for putting that on the table. And I'm hoping, I'm not gonna call any names, but I'm hoping more voices come to the table to kind of say more of what we were having the conversation about yesterday. And one of the questions was, how much do you have to kind of center the discussion and measurement of racism itself, right? And how much do you kind of talk about the systemic to be able to get at intervention and disruption? So yes, I hope more of that conversation comes out. Please go ahead, take the next one, Candace.
Okay, go here, and then it's. Thank you so much. That comment, I was going to make a different comment, but I'm going to follow up on this first, is so important and insightful. So as I was writing about my piece, and I was trying to figure out where's the line between documenting racial differences that is important because it points to race disparities, and documenting racial differences that is counterproductive because it is rooted in this assumption that black bodies, for instance, are different than white bodies, right? I think we need to be, I think this is actually a great opportunity because I think it is something that we need to break down and that we need to be able to very clearly address where one is important and the other one is counterproductive. So that's the first thing I was going to take. So thank you so much for saying that. The other thing is actually just a general thank you, because as you guys started talking, I already had a little bit of a brain explosion, which is also probably what you were doing, plus coffee in the morning, and my brain is still working. But I have been struggling over the last several months with the question of how do I find race in my particular topic, because it's actually not particularly recorded, except maybe for the last 10 or 15 years. And I actually whined to Adam about this yesterday. I said, it's really not there. You know, you don't know whether these infants who are dying are white or black. But then when you put up that image that you started with, I thought, well, actually, this is not just a historiographical problem. It is also a topic, because they're invisible and they're dying. And their death is partly rooted in their invisibility, and that we're not looking for them. So now I know what sentence to write, and I'm really grateful for that. Thank you.
Go ahead.
Yeah. So I was making a note about, in response to the comment that started this off, about this, there being a kind of, maybe one way that we could be thinking about this is that there's a central problematic, that this issue is one of the central problematics that is emerging in bringing these different fields together, right? And one of the ways that we have been talking about it, actually amongst the steering committee, is as a question about reifying race versus studying race, right? And where do you, and it's kind of related to what Johanna just said, like where do you draw that line, right? But that's one of the ways we've been articulating it, as a kind of problematic around studying race and reifying race, and always being aware of that tension and trying to sort out for yourself where that tension is in your project, right?
And I think actually, as important as
Need the mic.
I'm sorry. As important as it is for us to become clear about this, I think this is a really important public education project. I think the problem, there are many problems with race in the United States, but the problem with the current political discussion surrounding race is that there's no understanding that there are differences in terms of how we talk about it and what we count and what we shouldn't count.
And I mean, to the extent that I want to add to that is that I think when I think about race and I think about the body, I mean, I think history is part of the body, right? Social context is part of the body. And just part of the way I am kind of responding to that first comment, I think you can make a fairly cogent argument, and Dorothy Roberts is one of the people who has done this already, is that you can make a fairly cogent argument that, you know, racism is not a product of race, but that race is actually a product of racism, and that it's That's right. These efforts to sort of create these hierarchies and social hierarchies, that race is sort of a benefit of that. Like that's sort of the way you objectify these forms of exclusion. And so when we think about it that way, I think, we can come up with much more nuanced sort of understandings of how race kind of gets assigned to different bodies. One of the things, though, that you guys just were talking about that I think is sort of really central to this, and that I just have sort of been ruminating on for a while, is that putting the notion of justice at the center of health endeavors, and even how we understand definitions of health. And I say that with this in mind. Like a lot of times when and I know this definition has evolved somewhat depending on which groups you sort of talk to about it. But to the extent that we often think about health as being the absence of disease, right? That's not like a race-neutral construct, right? Because how we kind of go about defining disease is also, often predicated on this idea of black being abnormal, right? But the idea of saying that health is sort of intimately tied to notions of justice, like if we bring that in with sort of a jurisprudence kind of angle, when legal folk talk about justice, they talk about making people whole again, in various ways. And so when you talk about health through the lens of sort of making people whole again, but also making communities whole again, I mean, Michelle, part of what you were bringing up is, wrestling with this idea of what it means to be human. Part of what we're talking about is how do we sort of create that sense of, making our communities whole again in that regard, through that lens of what it means to be human. The thing that I would only add to that, though, I think, that is also worthwhile, is that when we are talking about making things or communities whole again, we are also, and we need to be having, I think, explicit conversations about who we are including and who we are not including, or what we are including or what we are not including. Because when we use the language of universalism, right, when it's everybody, that usually is a very effective tool for hiding sort of efforts at exclusion, right, efforts at creating hierarchies. And so I think like that is, and I don't have an answer to this that I think, sums this up in any kind of convenient way. But I do think like when we are talking about the whole, if we avoid the hard part of that, that is to say the things that we're not including in that, then we are much more likely to reify in a less transparent way the very types of inequity, the very types of exclusion that we are working to mitigate.
Go ahead.
I have a thought about that related to just the interdisciplinary project that we're engaged in. I do think that in each of our fields, we're often encouraged to think that we are trying to find the answer, right? I thought of it as you said the word. I don't know that I have the phrase. I don't know if I have the answer, right? And I think when I said that we are invested in a systems approach, right, one of the conceptual underpinnings of that is the understanding that actually no one of us is going to have the answer, right? There's going to be something that you say or that you say that I have not thought about as a literary scholar, as a psychoanalyst, as a cultural critic. And a systems approach is believing that there are multiple factors, but also that no one researcher is going to be able to capture all of those factors, that we have to be able to be in conversation with each other. So our perspective matters because it brings in certain angles of inquiry, but it's then laying that out on a table with other angles of inquiry that actually gets you closer to a systemic approach, right?
Absolutely, and if I could just add one more thing, that part of the conversation and the setup, going back to the originating question, so rich, is in why we conceive of the project in the way that we did, and why the next conversation we're going to, with Patricia's wonderful talk, very excited as a prelude, is the origins and how we understand race in its longue durée. Right? Because we can talk about race and kind of modern constructions of race and even shifts in the 90s on, and we can go all the way back. One of my favorite books, Racism: A Short History, right, takes you back and then forward, and you see the ways, not just in the US context, but in the global context, we have tried to hide and make visible race as a construct. So if we look at Brazil, they're like, oh no, we don't need to count race. we don't think race is real. You can see race in its impact, right? And so the tensions in the way that we wrestle, we can benefit in the systems frame of saying, what do we understand in the here and the now? What can we learn and what can we borrow? If we understand race as a global construct that is reaffirmed not just within our borders, but without them, what does then that help us to do?
Yes, I really appreciate the sort of bend of this discussion, and I want to bring up sort of 2 points. The first is around measuring racism, and I think I want to center the idea that all categorizations are political and capitalist actions. Like, there is a political motivation behind categorizing, and if you look at the sort of way that we have created categories in the United States from our like census and things like that, those have shifted over time based on policy choices. And so in that regard, racism and race cannot be extricated from each other, which is something that we're kind of all talking around. But when we're talking about measuring racism, we have to think about it, in my opinion, as a sort of a multidimensional aspect and a time-varying aspect to it. And so racism, systemic racism, is embedded in our society, right? And this is tied to my second point, because we're talking about disrupting structural racism, but structural racism is so nuanced and multidimensional. Like, what aspect are we trying to disrupt? Like, what are we trying to disrupt? The economic aspect? Are we trying to disrupt the just the like internalized aspects? There's so many ways, and so we use this sort of this chunky heuristic of saying race, and this is a proxy for exposure to racism, which I think is helpful in sort of shifting the narrative of pathologizing racial groups into saying that race isn't the issue. But it's also chunky and imprecise, because race, even though it was created by racism, people's response to it has made it so it's just not deficits, right? There is racial strength. Black people have strength that is unique to them because of existing in and thriving through a racialized society. And so when we say race is a proxy for racism, which is kind of where public health has kind of landed today, we're throwing away all of that benefit, and we're not having precision in what elements of structural racism, because my internalized definition of my race versus how people racialize me from day to day versus how people record my race on the population health, those are all different elements and have different relationship to all the different structural racism, institutional versus local versus internalized. And so I think this conversation needs a lot of precision in what elements of racism and race are we measuring, what elements of racism we're trying to intervene on, because that allows us to then have a sort of structural response to structural racism where we're acting on multiple levels because we recognize that those levels vary. I hope that made sense.
Oh, it made plenty of sense. We were having a conversation yesterday, and I'm looking at my dear colleagues to join us, but that part of the conversation we were having in the Black Bodies Cluster group yesterday was the need to be precise on the ways in which structure is impacting health, right? And so because structure is kind of global, robust, and ephemeral at the same time, right? It's substantive and shifting, what does that look like, right? How are you conceptualizing and the need to kind of be explicit in kind of the mechanism? What is the way that structure is impacting that particular health outcome? Absolutely. So that was absolutely our conversation, right, of marrying social theory, and that what happens when critique yesterday is a theoretical, right? Because then you think, well, I'm just looking at, race-related stress, right? And you're like, well, the impact of that stress is an outcome, and it's not the body itself. It's not the experience of stress, but it's the conditions. And so what are the conditions? One of the examples that we were talking about was managers, right? Managers in a labor market. And what would it look like to control for racial harm in managerial relationships, or the harm of not knowing if you've been passed over for a promotion? Those sorts of things, like, well, you would need to create an alternate environment where there was structure around promotions. We're like, well, what if you look at the military versus the US population, and kind of stress-related biomarkers for promotion, those kind of middle-aged and above in that scenario, versus kind of in the military where there's kind of guidance. You don't wonder, you're not kind of questioning of, oh, did I get passed over? There's a formula. It's kind of more transparent. Are those folks going to be better right, more well than those who are kind of navigating in public. So that was a sense, and Derek was in our conversation, he said, but in that example, you are postulating a very specific way that structure is impacting health. And that's important, but that's not all that structural racism is. That is one dimension. And so even in our very rich conversation, that was like an hour of us going around, we were still at a piece of how structure was impacting health. But I do think that it's that kind of marriage of theory and outcome that is rich. Comments? Again, comment questions are invited. Comment questions. Yeah.
First of all, thank you for this conversation. My head is kind of churning about how do we actually change the healthcare system overall. And if I just be very selective in my thoughts, are like, how do we impact the people that have the most impact on our lives, which are the healthcare providers? And a common thing is, at least in medical school, is said, treat everyone the same. Right? And so one of the attacks is when you discuss racism and its impact on health outcomes. It's, well, I treat all my patients the same, right? And that on its own is so problematic because we know, so I'm an OBGYN. We know the aspects of weathering, right? We know that racism actually has an impact on a pregnancy outcome from preterm labor and, God forbid, death, right? So there are actual impacts that we can measure and we can see. So you can't say necessarily, I treat all my patients the same. Because that's meaning that you're not even understanding what's actually happening to those patients that you are taking care of. Especially within the Black community. You're not listening, you're discounting them and their lives and the impacts that is. I always wonder, how can we make a difference in the actual system, schooling? I understand what we're doing, but when you speak to physicians at large, I don't know that much about the nursing community, I'm sorry, but when you speak to physicians at large, they don't see as much the impact of racism on their outcomes because, like I said, they really believe in this, I treat everyone the same kind of theory. So what is it? Why are you talking to me about this? And they think it's the other person. And so that's my only comment is like, what can I do to perpetuate, to actually have an impact on the system that I have the most control over, maybe.
I have a thought about that. It's a more humanistic kind of frame, but I think it's important. So why I really appreciated the discussion that Chiduberi's illustrations generated. You said, how does one incorporate a sense of difference in the system? And often, difference is understood to be something that we carry as Black people, right? And so there's the norm, and we're the ones who are different, right? The thing that was interesting about Chiduberi's illustrations for me is that it demonstrated something about that there is a grounded white perspective in the field that has made the white anatomical body visible and the Black anatomical body in these illustrations invisible, right? So in a way, white people, quote unquote, are different too, right? It's just that their perspective is dominating, right? And there's something, I'm not even sure if I'm putting it as clearly as I can, but there's something about, it's a part of bringing the universalism actually down to the ground. That's saying there is actually no actual universal perspective. There is a perspective grounded in a certain set of bodies. And these are all the ways in which the perspective grounded in those bodies has shaped the field. And an impact of that is that it has made other bodies invisible, right? And I feel like this is a little bit, when I've been trying to think about what shifted after George Floyd's murder, this feels, in the awkward, clumsy way that I'm articulating it, this feels like a little bit of what shifted, is suddenly the whiteness of the bodies shaping the universal discourses somehow suddenly became a little bit more visible as white bodies, not just as the human, right? And so it's just something, so in a weird way, we often kind of instinctively think encouraging a system to accept difference is about them accepting us, right? Because we are the embodiments of difference. And I'm actually feeling like, well, another move is actually to accept themselves as the embodiments of difference. It's just that they are a more hegemonic form of difference, because we are all human, different from each other, but their perspective has been hegemonic, right? So it's just something to think about.
Absolutely. Go ahead. Oh, sorry. No, please. No, go. We'll get both. Go ahead. No, you can go right there. Or was it a, yeah. We've got 2 more comments on the floor. We will make sure they both get here. Both comments will be heard, please.
So sorry, but thank you. And I told Michelle I was just going to listen, but I can't help but jump in. I'm thinking about Tom Sequist's study from quite a few years ago when he was at Harvard, actually asking physicians, are you racist? Do you know everyone who's racist and anyone who's racist? And then they kind of went through this process of forcing people to consider the data of their own patients and not letting them make any other conclusion ultimately than, yes, I may not perceive myself as racist, but I am treating my patients differently, and I can see that in the outcomes. So I think data is a really useful approach to counter all of our assumptions that we are not racist. But I'm also thinking about the fact that that paper was published a long time ago. It was really strong, and it was really well-designed work. So we shouldn't doubt it. We should have made changes. We should be in a different place, and we're not. So I'm just thinking about, I don't think we have educators here. I know you guys are all educators, but we don't have K through 12 kind of educators here. But I'm thinking about this idea that we're so afraid of racism in the United States, and we're taught so strongly that racism is wrong that we can't admit that we're all racist. And it would be so much more useful if we could get over that assumption, right? All physicians should assume I'm racist. And then take steps to counter that. I mean, everybody should be having that critical thinking of themselves, coming from a place of, I don't want to introduce harm to anybody, but I am because I'm human and I see those differences and I've been taught in a certain way. So just reflecting on we need to be able to just get rid of that fear almost, of that self-criticism, and just deal with it. And data can be a really helpful way to do that.
So I was going to make a different comment, but I want to kind of respond to that. That's the idea of a group being willing to admit they're racist as the hurdle that needs to be overcome to then be able to make progress has been the foundation of a lot of anti-racism organizing for a long time. And I think there has to be a fundamental question of, is that too high of a bar? Because people get stuck trying to jump over that bar and never get past it to be able to move. So there's part of the conversation, I think, has to be, how do you frame the problem that you're describing, the hurdle that you're trying to get people to jump over, in a way that makes it a little bit lower of a bar to then have them better understand it and experience the phenomena that you're talking about, and then potentially reintroduce the term. But the idea of just telling them, okay, you have to admit that you're racist and therefore move forward, most people don't get past that in a lot of the organizing work that we've seen over the last few decades. The quick thought, other questions. So you started with this idea of disrupting structural racism, and so I would love to see more. I guess these are just big picture thoughts. I would love to see you actually lay out how you're thinking what that would actually happen, what this project ultimately, is there some bigger conceptual model of what is the contribution that you're seeing this intervention make? And actually, I was also thinking of, given, Michelle, how you laid out sort of the humanist, the social science, and biomedical, like how each of those brings something. You laid out beautifully how they each bring different perspectives, but how you see them kind of all filtering into this conception of what disruption looks like. And concretely, how does that relate to the creation of the equitable health outcomes that you're talking about?
Yeah.
Because I think mapping that to, and even then having seed projects that would follow from that framing as opposed to having them kind of as a separate project could actually be really helpful, because it would actually help to test the theory that you're talking about, and then actually sort of, you know, again, bite the little parts of the elephant or whatever the awful example that you want to give. I never thought eating an elephant was this. I always thought it was a disgusting example, but it's the one that we tend to use the most. Sorry.
So we probably have different answers, but I had an immediate answer partly based on actually your first comment. And so this might be the psychoanalyst in me, and one of the things that praxis has given me as an academic is a way to break down an interaction into smaller units, right? The humanist in me is all about the history of race, the kind of macro conceptions. But that point you just made about, obviously, an anti-racist internal agenda is our bar, right? And then the recognition that, yeah, but if we're starting the conversation there, this country might actually be ready, and may not be ready for that. And so then as researchers, if all of our energy is still going to all 100 of different ways we have to develop that bar, right? And we've totally missed, well, is there research we could be doing about what are the steps leading to that, right? What is an action, et cetera, et cetera. And, as a psychoanalyst, it's micro interactions that you're focused on, right? So just that move. So one answer of many that I have right now, this is why the cases, I would not say that at this point maybe Anna does, but at this point I don't have a systemic theoretical conception yet. I don't think I think the steering committee and Anna and I will be kind of trying to draw that from everything, right? But I know one of my ambitions is that we can offer to the Robert Wood Johnson Foundation, and in a public educative, as Johanna said, move also, a different set of starting points and questions, that the creativity of bringing us all together might produce unexpected, counterintuitive starting points for research than the normal lanes that we have been traveling so far. And so that is one example, the idea that, maybe the anti-racist bar, actually what we need is the research that leads up to that. Maybe that's too high a bar. That's a good question for us to be thinking about, right?
Yeah, and my answer is very much in line, but in some ways, this setting the terms of the conversation this way is the first intervention, right? And that the participants you hear and those on live stream, hearing and dialoguing, and the products that come from this, if we take this as a starting point, right? There's a way that the way that you think, and I've already heard this from other folks, is not going to be the same. You're going to reference different languages, different points, and then the work that comes out of this, so if we take this project as a beginning, right, then it takes us in many fruitful directions. And the goal of this workshop, and I said this to the group yesterday, is to generate many more questions than answers, right, to kind of frame out what is the agenda, what don't we know, in ways that move us beyond where our fields are, right, and that we kind of blur the marginal areas of our fields to create new space. And so that's really the goal of today's conversation. Thank you all for a wonderful session one. You have a brief break before our next talk. So thank you, and there will be many, many, many more conversations like this. So thank you.
Behind, so just 10 minutes and then come back at 10:50. everybody. Reconvening. So it is my distinct pleasure to help us move along our conversation by introducing our next speaker for this morning. And so I'm going to tell you a little bit about Professor Patricia Akimi, who is an associate professor of English at Rutgers, New York. She's also the director of the Race Before Race, and the before is B4, the letter B, the number 4, mentoring network. And so that may even come up a little bit in our discussion with her. So the Race Before Race mentoring network already can get you thinking in terms of some of what we were talking about before. So she's the director of that network, and she's also, as an associate professor of English, a scholar in and a teacher of Shakespeare Renaissance drama and early modern women's travel writing. She's the author of Shakespeare and the Cultivation of Race, Race and Conduct in the Early Modern World. That was published in 2018. She's co-editor with Bernadette Andrea of Travel and Travail, Early Modern Women, English Drama and the Wider World, published in 2019. And she's currently at work on a new edition of Othello, the Shakespearean play Othello, for the Arden Shakespeare 4th series. This is going to be a collection of essays co-edited between herself and Maite Green Mercado, who is also one of the directors at the Institute. And this collection will be based on the Race Before Race Region and Enmity Conference that was held recently. And she's also working on a monograph about race, gender, and editing early modern texts. In 2021, she received the Warren Sussman Award for Excellence in Teaching from Rutgers University for outstanding and innovative performance in both the physical and the virtual classroom. And her research has been supported by the National Endowment for the Humanities, the Folger Shakespeare Library, the John Carter Brown Library, and the Ford Foundation. So help me welcome Dr. Akimi.
It's such a pleasure to be here and to listen to our opening conversation. I have to say, even though all the work I do, if something's written after 1630, I probably haven't read it, but some of the same questions that were asked in this room, those are the very same and really urgent questions that I talk about and that my colleagues talk about in our work. So it's a pleasure to be here. So if I press this green button, will that advance the slide? Okay, great. So I'd like to thank SVP Anna Branch and Michelle Stevens for inviting me to speak here today. Also, thank you to Robin Yarborough and Desiree for making my trip actually happen. Thank you. I am here. And it's a pleasure, especially because I am inspired by the Black Bodies, Black Health projects. So these are projects that, from what I understand, seek to address disparities of access, to understand hidden histories of neglect and abuse, and to imagine the possibility that Black bodies might receive equitable treatment and care. And I'm going to begin today with a very old proverb. It's known as Ethiopem lavare, or to wash the Ethiop. And Ethiop is a term that in the period that I work on, the 16th and 17th centuries, it's a general term that refers to people with dark skin, people originating from Africa. It's a catch-all term. So washing here refers not simply to bathing someone clean, but to whitening them, washing them white. The proverb appears frequently in early modern texts of all kinds, and it's similar to other sayings that reference futility or unchangeable nature, like the leopard cannot change his spots, or don't sow your seed in the sand. Here, it's included in an emblem book. This is an anthology of proverbs with an illustration and often with an accompanying poem. This proverb warns against labor in vain. The proverb's accompanying image and the poem's central metaphor refer to scrubbing or washing black skin in an effort to make it lighter as an example of such futile effort. And I'll read a little bit of the poem that goes with this particular image. Leave off with pain the blackamoor to scour, with washing oft and wiping more than due. For thou shalt find that nature is of power. Do what thou canst to keep his former hue. This emblem offers more than a reminder not to waste our time or take pains futilely. The implicit claim the poem makes by way of the central metaphor is that while the natural state of the blackamoor is undesirable, his blackness is indelible. He is insufficient as he is, and he cannot be improved. This unhappy condition, undesirable blackness, amounts to a stigmatized somatic mark and the history of racism in the treatment of black bodies. This is an arbitrary sign that has taken on specific and negative significance, and it's a jumping off point for our discussion. There is no information in the emblem as to why blackness is undesirable. This information must be inferred by a reader familiar with the specific social meanings of blackness at the time of the emblem's production. And this has been the work of a generation of scholars of race in the pre-modern world. And I've included here a group of some of the most foundational and some of the newest work in this field. In the seminal study, Things of Darkness, by Kim Hall, she connects the trope of dark and light, or black and white, to the formation of English national identity. White and black delineated a spectrum from beautiful to unlovely, from desirable to undesirable, and finally, from self to other. Hall effectively linked the practice of aesthetic discrimination between women, the discourse of beauty, with the moment of English economic expansion, that colonial moment that was mentioned earlier. The stigmatization of blackness is thus directly related to the need to reestablish not only male, but also now English and European hegemony. To this important formulation, I would add that within early modern racial ideology, the indelibility of blackness, so commonplace as to be proverbial, may be understood as an incapacity for improvement or self-improvement. And I would include efforts to improve one's own health under this rubric. The pursuit of preventative and curative treatment, what early modern English people would have called physic. Within this rubric, the impossibility of improving black skin by making it lighter is linked to the idea that black people cannot be improved and cannot improve themselves. The impossibility of improvement itself becomes an attribute associated with dark-skinned people. As a result, blackness or any stigmatized somatic mark may invite and justify heavy scrutiny, harsh judgment of one's conduct, even as it comes to signify detrimental attributes, such as an inability to improve oneself due to a lack of self-knowledge or a lack of imaginative capacity. These forms of oppression and prejudice are the byproducts of a system in which social identity is understood as both fixed and fluid. The notion is essential to our understanding of race and class in the early modern period, a period in which a privileged group was characterized by its capacity and desire to improve, while others were marked by a devastating lack, an inability to be better and even to know better, that is, to know that they should be better. Studying early modern texts, images, and objects allows me to explore long-standing beliefs about the nature and significance of differences between peoples. It is not inevitable, nor is it rational, that phenotype should come to signify social difference. And yet, for early modern English people, bodily markers were inextricably tied to the relative worth of different social groups. Early modern fictions of racial difference relied upon the idea of shared ancestry, family origin, or lineage. And here I'm showing you a detail from an illustration of a biblical family tree, Jacob and his sons and their descendants, who are understood at once as a family and as a tribe or nation, a race, the Israelites. Kinship networks, in turn, are linked to regional, religious, cultural, linguistic, and other forms of identity. And these ideas lead in turn to assumptions about the way shared physical traits or other traits are linked to, shared physical traits are linked to shared moral traits or capabilities. So these images come from compendiums of the world, descriptions of the world's kind of different peoples. They're really popular in the 17th century. And on the left, this image illustrates typical people from Morocco. And on the right, there are people of different ranks from Ireland. These fictions of difference were elaborate enough to be imagined to encompass all peoples everywhere, and they were imagined as static, unchanging racial categories. Such a theory of static difference is unable to account for the fact that racial groupings can never be finite or discrete, since group members must continually be evaluated for inclusion or exclusion as a result of changes such as their movements between territories, their intermarriage, their production of mixed-race progeny. And here I'll show you two images from recent Shakespeare productions. Oops. There we go. Thank you. Okay, so on the left is an image from Othello in New York in 2018, Shakespeare in the Park. And Othello is a play in which a dark-skinned man, a foreigner, falls in love with and marries a Venetian woman. It doesn't end up well, but still, the story is there. And on the right side is Aaron from the play Titus Andronicus, who also is involved in an illicit affair with a white queen. And that's his baby that he's holding there and defending against those who would take its life. These plays dramatize the instability of supposedly immutable racial categories. Thus, what remains constant across the broad range of meanings of race throughout the early modern and modern periods is the emphasis on a need for methods by which racial difference can be detected and affirmed. The word I heard before in this room was measurement. In these strategies, the body plays a crucial role as a tangible and legible record. Despite the fact that the meanings and markers of race change, and they range from the spiritual, think of professed faith, heresy, heathenism, conversion, to the internal or the hidden, think of ideas about pure blood, to the behavioral and the superficial, think of ideas about relative civility, custom, styles of dress. Despite this variety, the body provides a reliable discursive space on which to inscribe significance. And these images are from a different compendium, one of all the fashions of the world. And the figures here are labeled. The first one says blackamoor. These are in Italian. The second one says virgin Moor, or a young woman, a maiden. And the third one says the Moor of condition, or the wealthy Moorish man. And it presents not only details of dress and weaponry, but also bodily traits like skin color, hair, facial features, as typical or representative of a specific group of people from a specific region. And I'll leave it to you to consider whether or to what extent such images not only illustrate, but evaluate positively or negatively the group they depict. Through my research, I work to understand when and how the body is recruited into systems of social differentiation, systems I've come to think of as racial projects, since the groupings that are produced through such systems are racial that is, imagined to be indicated by bodily marks that are inherited or inheritable, permanent, and signifying more metaphysical traits that effectively limit capacity to desire or achieve improvement, whatever improvement might mean in a given context. Skin color, blackness, is a form of bodily difference that signified for early modern English people and which continues to signify today. The body both reveals and conceals. It communicates those things we wish to share and some things that we do not. And it is always available to be seen and interpreted. I treat all my patients the same, whether we will it to be so or not. We interpret the bodies of others, and we use the evidence of the body to organize them into categories. We find meaning in the sex of the body, in its shape, in its color. We teach ourselves to communicate meaning through our bodies, using the body to perform according to set rules in order to maximize the benefits of self-representation and minimize the drawbacks. Despite our best efforts, the body may mean in ways that are not deliberate, not alterable, and in ways that are ultimately detrimental to us. Moreover, the habit of grouping people by their shared bodily characteristics reinforces and highlights some somatic signs, enabling societies to discriminate wholesale against anyone who possesses these signs. The fact that the meaning of such bodily signs of difference may change over time, appearing and disappearing as well, should lessen the significance of supposedly racial difference. Instead, racial logic is characterized by the imagined rigidity of its arbitrary categorizations and the perniciousness, particularly, of the stigmatized meanings that attach to some of the somatic signs that correspond to such categorizations. Thus, for example, the bodies of working people are marked by the signs of manual labor, and those same signs are connotatively linked and come to symbolize an inability to know or improve the self. Working bodies are roughened, hardened, yellowed, browned and blackened, pinched and misshapen, bruised and beaten. These bodily marks in turn are made to mean. Hardness comes to signify a lack of imagination as well as polish. Pinched bodies are monstrous, inhuman, and unapt for education. Blackened skin and blackened reputation go hand in hand. Bruised bodies are misbehaving bodies, guilty bodies always subject to punishment. Racialization is the byproduct of the very material and discursive practices of scrutiny, discrimination, violence, neglect, and exclusion that such somatic marks evidence. Some scholars of race have pointed to the 18th and 19th centuries as the historical moment in which pre-modern racial thinking gives way to modern forms. This teleology toward modern racism charts shifts in racial thinking that lead ultimately toward scientific classification of races understood as rigid, monolithic, and pervasive, and used to justify acts of physical and epistemological violence. In this teleology, early modern notions of race were cultural constructions with fluid and multiple meanings. Over time, the concepts hardened, giving way to notions of race as biological rather than cultural, rigid and monolithic rather than fluid and manifold. But I want to push back on this idea a little bit. The 1854 treatise Types of Mankind, a collaboration by Josiah Nott and George Glidden, made a big splash in 19th century history circles and among lay readers. In a section entitled The Comparative Anatomy of Races, Nott expounds upon the theory of polygenism, the idea that the races of man are in fact entirely different species arising, he imagines, from wholly different original pairs, more than one Adam and Eve. And underneath the skulls on the right, the first one says Caucasian, the second one says Mongol, and the third one says Negro. And you're supposed to observe the differences between these skull shapes. In his vision of humanity, The Jew, the Celt, I'm quoting now, the Jew, the Celt, the Iberian, the Mongol, the Negro, the Polynesian, the Australian, the American Indian, end quote, are discernible as different based on the shapes of their skulls, which may also serve to support theories about differences in intellect, in ability, and civility. In this text, difference is marked on the body. The significance of that difference is inferable because the shapes of the skulls reveal the capacity of the minds they contain. Denying the possibility that one species of man could change into another, he scoffs. Quote, no terrestrial causes could metamorphose a white man into a Negro or vice versa, any more than they could change a horse into an ass, end quote. Knott's choice of metaphor is telling. He compares what he believes to be a lesser species of man to the most pitied and ridiculed of beasts. His evidence, the shapely skulls, is offered as absolute and positive evidence of undeniable differences between groups. This science trumps every terrestrial force for change or dissolution of the boundaries between racial groupings. Knott's assertion that the human races represent different species and that metamorphosis from white to Negro would be impossible gives shape to a vision of racialism that maintains a belief in the impermeability of boundaries between groups, the impossibility of moving between categories. In recent decades, studies have identified and explored somatic, political, religious, national, regional, and other methods used to categorize humans into groups in the pre-modern period. These same studies have also attempted to understand the ways in which individuals nevertheless moved within and between such seemingly rigid groupings through conversion, through passing, travel, intermarriage. And again, here I'm showing you some recent and seminal scholarly work in this vein. Mine is the little one on the side. Ultimately, the complex set of ideas associated with race combines as much in the early modern period as today a belief in immutable differences between groups and a simultaneous awareness that group distinctions may alter and dissolve over time. This contradictory quality is characteristic of racial thinking, in which opposed ideas can coexist and support one another. Race is a structural relationship between, on the one hand, fluctuating ideas about human differences, and on the other, shifting power relations in a society. In my work, I've sought to denaturalize and break apart, disrupt. And to break apart the concept of race in an attempt to mitigate its most damaging effects. Rather than positing a trajectory towards modern concepts of race, I seek to establish a means of detecting a persistent and particular kind of injustice, the signs of which are as fluid as they are injurious. The particular kind of justice I explore is the fact of immobility, despite the promise of betterment, and the fact that immobility is naturalized by an indelible, or believed to be indelible, somatic mark. Such injustice causes pain to those who experience it, and sometimes we can glimpse that pain even in early modern texts in ways that are unmistakable. As Jonathan Burton and Anya Lumba note in their introduction to Race in Early Modern England, a great reference text, the history of race is both protracted and erratic, possessing a protean quality, a range of concepts, themes, and mechanisms for assigning different values to human beings arise, mutate, go dormant, resurface, relocate, and adapt anew, end quote. This strange quality makes studying race, or rather, the painful effects that racism causes, challenging. However, we should not be daunted in this effort. Understanding race and undermining racist thinking must begin with accepting that the power of race is its slipperiness. Learning how to wrestle with this slipperiness is itself the emancipatory task. Learning how to recognize the pain that racism causes can help us to recognize race in any period and to set aside the fiction of immutable difference. Race is a realm of ideas about difference. Wherever race is, and it is everywhere, processes of inclusion and exclusion are always underway. Processes that must necessarily be of great benefit to some and great detriment to others. The specific criteria by which individuals are evaluated as included or excluded in groups, the shared qualities, nature, or borders of such groups and their function and meaning are constantly in flux and so arbitrary at times to seem nonsensical. Race is nonsensical. Race is also real, however. It impacts my life and the lives of others, everyone. My interest then is not in defining the contours of specific groups, but in identifying the processes of inclusion and exclusion by detecting the pain that such operations inflict, and in doing so, exposing the workings of racist thinking that link a social process of differentiation, always connected to existing structures of power, to the naturalization of such difference, the stigmatization of bodily markers imagined to be biological, imagined to be inheritable, socially meaningful, indelible. I want to know how racist thinking is justified by the assignment of meaning to natural and thus indelible differences between human bodies. Shakespeare, warning, here's the Shakespeare part of the talk. Shakespeare stages these essentializing practices as the infliction of painful, permanent bodily marks. Characters like Dromio of Syracuse and Dromio of Ephesus, the enslaved twins of the Comedy of Errors, they're in all of these pictures here, are the recipients of such gestures. They're imagined to be oblivious to such pain or its injustice, but they reveal through their confusion, they're constantly being beaten, kicked, hit over the course of the play, and we're supposed to understand as audience members that this is fine because they're servants and sometimes they're called slaves in the play. They reveal through their confusion, their discomfort, their objections to painful mistreatment, an undeniable awareness that also functions as a critique of the process of racialization. Early modern drama, and Shakespeare's drama in particular, offers a sustained critique of the dominant ideology of racial difference as characters wonder about and investigate the process by which such bodily marks are inflicted rather than inherited, and the extent to which such marks might be removable or at least redefinable rather than permanent. Drama is uniquely valuable to the study of race. I know you don't believe me, but just hang in there. It's uniquely valuable to the study of race because staged narratives emphasize unpredictability, thrusting uncommon figures into unusual circumstances. Drama also allows literary critics to examine the relationship between playwright, players, and audience, to evaluate the collaborative production of subjects as gendered and racialized, and of bodies as symbolic. The performance of physical violence between racially differentiated characters, too, brings us as critics closer to a tangible connection with the lived experience of individuals in the distant past. Shakespeare's plays frequently feature figures unmoored from their identity positions. They are shipwrecked, lost, disguised. Audiences find characters adrift in unfamiliar geographical and social spaces, without family or friends, places where their identities are not readily discernible. And I'll just point out the image on the bottom right is from a recent film version of Twelfth Night, in which they fully embrace the idea that in this play, a pair of twins wash up on on the shore of an unknown country and have to make their way in the world. In this version, they imagine it as the experience of a Mediterranean migrant who washes ashore and in England, in London. In these situations, which are, broadly speaking, more common than sensational in a world in which people move, things change, those encountering such figures attempt to employ a universal code to evaluate and discern the identity and relative worth of unfamiliar people, their nation or culture, their sex, their religion, their rank, their race. Yet, the body disrupts this process by suggesting deeper natural differences that cannot be ignored. In these heightened circumstances, which nevertheless ultimately represent the everyday work of processes of identification and group formation, the body emerges as a meaningful, though unreliable, indicator of group identity. The characters identified as both different and lesser in the plays are also somatically marked in ways that signify failures and culpability for those failures. The bruised bodies of Dromio of Ephesus and Dromio of Syracuse are evidence of their and of all slaves' innate moral failings. When bodily marks function in this way, they aid in the naturalization of the inferiority of whole groups of people who are then subject to oppression that is justified in the eyes of society. This racializing process creates groups deemed incapable of self-improvement, even as such groups are systematically denied access to strategies for improvement that might prove them able and willing to rise. Mutability, the ability to change or improve oneself, becomes a powerful marker of privilege, while immutability, manifest as a bodily and racialized mark, is an inheritable and unshakable determinant of fate. The study of early modern conduct literature, these are books about improvement, reveals the interdependent relationship between race and class in the period. There's a growing fascination with mutability, the possibility that you can improve yourself. This is like a new thing in the late 16th or early 17th century. You're not born a serf, die a serf. Maybe you could change yourself. Maybe you could improve yourself. You can do that by engaging in certain activities. Let me show you an example. Okay, this is one of my favorite ones because it's funny. This is a book about fishing. So you're a young, early modern person interested in improving yourself. You go to the bookstall and you pick up a copy of The Secrets of Angling, which is an old word for fishing, and it's going to teach you about this form of exercise. But it's not just any form of exercise. This is a form of exercise that will make you not only healthy, but I want to say cool, I guess, like impressive. And so this is the frontispiece. So the title is up there, and then there's a little image underneath. There are two gentlemen. They're both fishing. You can see they've got their fishing poles, and they're catching something. But this book, in successive reprintings, the two gentlemen's fashion that they're wearing is updated to match whatever the current fashion is at the time. So when it comes out in 1613 versus 1620 versus 1623, their costumes are updated, because it's intending to show you that this is a sport, an exercise that you can engage in to improve yourself socially as well as physically. Now, why is this important? So in this book, fishing is distinguished from commercial fishing. Anybody can fish. There's fishing and there's fishing. You can fish for sustenance. But here, it's become like a contemplative outdoor exercise appropriate to landed gentlemen. Each form of conduct that you can engage in and its concomitant body of conduct literature tell a story about the ways bodies may be recruited into attempts to distinguish between those who have been cultivated and those who are uncultivated or incapable of cultivation, improvement. And let me show you another example. So, like fishing, farming is another activity. Anybody can farm, but you can farm and you can farm. If you do farming the right way, it turns you into a gentleman, an impressive person. In The Tempest, another Shakespeare play, husbandry, that's farming, is reimagined as an art form practiced by members of a landed elite whose visions are executed by agricultural laborers who dig in the dirt. They're not important. In conduct literature in general, cultivation is a process of improvement through education and through skills like these, and also a process of denigration in which undesirable qualities are enumerated so they can be eschewed. In husbandry manuals in particular, there is a practice called pinching, a withholding of sustenance, a purposeful withholding of sustenance, or an application of pressure. It's a basic technique, and the manuals offer advice about how and when to pinch things, pinch plants, pinch livestock, pinch workers. And you do this by withholding food and water or supplies, or by actually nipping and pincing at them when you're gelding horses, for example, or pulling weeds. And this is an example of a tool designed by Jarvis Markham, who was a popular author of husbandry manuals, if you can imagine such a thing. And this is a pair of pincers that's designed to help you do your pinching. If desirable qualities are produced through continuous supply of attention, undesirable qualities are produced through neglect and deliberate injury. Thus, in The Tempest, the same kinds of activities that produce Ferdinand and Miranda, the young, attractive couple who are aristocrats and will get married by the end of the play, also create and indelibly mark another character, Caliban, who is an indigenous person on the island and is made to do enforced labor. So they do the same activities, in this case, husbandry, but in one instance, it produces this, in the other instance, it produces that. Continued deprivation by unseen forces comes with visible physical consequences for Caliban, who's plagued by pinches, and that's the word that Shakespeare uses throughout the play. Caliban fears Prospero's revenge. Prospero is Miranda's dad. He says, "From toe to crown, he'll fill our skins with pinches, make us strange stuff." Prospero says he'll make Caliban more pinch-spotted than a pard or cat of mountain. And when Caliban predicts his own execution for his perceived misdeeds at the end of the play, he imagines, "I shall be pinched to death." He refers to Prospero's preferred method of punishment, pinches, bites, and nips delivered by spirits from the island. Prospero's pinches leave Caliban disfigured and discolored, marking him as the abject other to the handsome couple, the weed that must be plucked rather than cultivated. In doing so, these pinches also give the lie to the idea that husbandry can cultivate people, because it includes the labor-intensive, physically grueling practices of farming, of digging, harvesting, foraging, all the tasks that Caliban is made to do in the play. Caliban's body then, along with his companions, along with his complaints of mistreatment and accusations of usurpation, activates an implicit and ongoing debate over the competing claims of hereditary owners and agricultural laborers to the land. So a careful reading of Shakespeare's plays alongside conduct literature in my work reveals a recurring critique. And it's voiced by malcontents, by social climbers like Caliban. It's embodied in the struggles of characters like Dromio, the Dromios of Comedy of Errors. And though these characters are not rewarded for their insights in the play, and they are not freed by their insights from the confines of the system, their complaints introduce audiences to the ironies inherent in ideas about racial difference. I suggest we need to hear and understand the pain voiced by characters whose bodies have been recruited into a justification of differential treatment. These characters' bodies are a painful reminder to them of the limitations and punishments inflicted by a rigidly policed social hierarchy. Through their complaints, however, we also come to understand the extent to which these socially inflicted marks become a double curse. They are the result of an inflicted and forced subservience. These marks can come to represent an enforced and subservient status, to signify a biological and thus inherited and immutably lesser nature. Shakespeare offers many versions of this outspoken figure, the social climber who is lampooned or despised, ultimately thwarted and often physically beaten into conforming behavior. These climbers are most often revealed, however, to be aware rather than oblivious, and thus equipped to offer eloquent and devastatingly insightful indictments of a society that blocks attempts at improvement and punishes even fantasies of upward mobility. These characters offer critiques of a system that is ostensibly held to be just and permanent, revealing an awareness of these categorizations as less than definitive, less than natural, and less than fair. These characters present accounts of how inferior status is not inherited, but assigned, stamped on, inflicted, and enforced, and then later presented as the dictate of nature. In the Comedy of Errors, for example, Dromio of Ephesus and Dromio of Syracuse receive repeated beatings as punishment. The play allows audiences to witness these errors corrected by means of a relentless slapstick violence and the beatings that plague Dromio and his brother, who are continually accused of failing to perform various errands on which they are sent. This form of punishment and the bruises that it produces were described in numerous domestic manuals, another kind of conduct literature about how to run your household in the best way. The bruises that result from such beatings might be perceived as temporary, but the twins reveal through their remarks that a bruise is in fact experienced as an indelible mark, endured from birth, indicating a moral and social inferiority that is hereditary and insurmountable. Dromio of Ephesus delivers a scathing critique, making it clear that his bruises, the marks of his servitude, are not natural or inevitable. They are the reflection of a communal disregard for his equal humanity. It's no coincidence that the characters who identify injustice in the plays are those whose bodies are bruised, pinched, blackened, or otherwise indelibly marked as lesser. This is the epistemic violence towards stigmatized others that lies at the heart of a discourse of self-improvement and a fantasy of universal accessibility. And I want to close with one final example. In recent years, my little brother, who's actually like 6 feet tall, he took up the habit of walking. This is an activity that was first elevated in the period that I study by and for elite practitioners in the 16th century. It's advertised in conduct literature as exercise for the body. Walking became another way to improve the self, improve one's health. In the English translation of physician, that's him, Levinus Limnius, in The Sanctuary of Salvation, Helmet of Health, and Mirror of Modesty and Good Manners, the title is actually much longer, he describes walking as an art and a privilege. He writes, "Amongst exercises that be mild, soft, and gentle, and less troublous or laborious are walkings abroad in the open air." Limnius's vision has the perambulator wandering in spaces tailor-made for his personal enjoyment. A garden, a vineyard, an open field, a high place, to take the free and open air, seemingly without fear of reprisal or interference. My brother walked in the evenings near his home in Central Florida. During his evening strolls, he was stopped by the police, asked what he was doing, where he was going, and who he was. This practice is sometimes called a pedestrian check or a ped check, and it has been described as a legally unsupportable stop by the US Department of Justice Civil Rights Division. Pedestrianism, which has steadily maintained its profile as a mild, soft, and gentle, as well as genteel exercise over the centuries, promotes the idea that free persons can improve themselves in mind and body by walking out of doors. For some, however, free wandering invites the check, a brief encounter that, like the pinch, leaves a mark, an interrogation that supposedly alleviates suspicions about the individual, but in fact reproduces suspicions about the group to which that individual is imagined to belong. The processes by which people prove their worth beyond their immediate gifts of high rank or wealth that some receive from birth involve not only their skills but also their improvements. The art of making oneself in such a way as to acquire the admiration and equitable treatment of others. The imperative to improve the self and the censure of those deemed unwilling or incapable of doing so is about the relative value of people, and it is used to justify unequal treatment. Even the evaluation process itself is injurious. Ultimately, it's a way of sustaining an underlying belief that some people are more valuable than others. The powerful assumption that underlies both the guarded admission of individuals to opportunities for improvement and the language of judgment used to measure relative success or failure in those attempts has to do with the belief that human beings themselves have relative worth, that people are not equal, but must prove themselves to be so. Thank you.
So everyone, we have about 6 minutes because we have to make sure, can we go a little bit longer? Okay, because we are watching time because your lunch time is 11:45 to 12:45 strictly. So what we'll probably do is maybe release everyone at 12 and you have 45 minutes to eat. So gotta make sure you're eating and come back, right? Okay, so we'll go until 12. So thank you, Patricia, so much. Let me open it up and I'll help Patricia kind of facilitate Q&A. So let me see, I have certainly some things to respond to, but let me open it up first. So we have Rachel right here.
Thank you. Thank you for this. Took copious notes, so I'm going to use a lot of what you have to say here. I was really struck by your description of the indelibility of blackness and the idea that self-improvement is not possible. And I'm thinking here, and I just want to see how we might include other figures, black figures from the early modern period, particularly in the Caribbean. And I'm thinking, and this speaks to the comment that my colleague over here in blue, I'm sorry, I forgot your name, mentioned about bringing in aspects of race that are not only about what is a mark of immutability, but also other marks of wisdom and insight. So first of all, I wanted to mention in the Caribbean societies in the 17th century, for instance, healers were predominantly enslaved and formerly enslaved women. And it was assumed that those women were capable of transforming the bodies of other enslaved Africans, but also white women in particular who visited them for issues of childbirth and other health issues. And I'm wondering how we can incorporate those women into the more intellectual conceptions that you just laid out. These are kind of more, and I'm thinking here particularly of Tatiana Sejas's new book, As If She Were Free, talking about how women negotiated in those spaces to create transformation, health, and as a negotiated reality, but really they were looked up to as healers. So I just want to see how that might fit into your overall schema.
Absolutely. This is such a great example because it sort of gets at what I find most intriguing, which is that we're able to maintain both this idea that people are unchanging or unchangeable, while we also, our lived experience is that that change is possible in all kinds of ways, and that the spaces for that change are intercultural spaces. and that knowledge, it comes from different communities, different backgrounds, and it works on us, whatever background we come from. How does that coexist with this other idea that miscegenation, for example, in the 17th or 18th century Caribbean or in the US context is something to be feared, something to be outlawed? It's very strange to me, but as a scholar, it's very interesting. I also think an important point that you raise is in looking at this sort of like slightly later period, so the Caribbean in the kind of late 17th century and into the 18th century, what we're talking about is what has happened previous to that moment to lay the groundwork for exactly the situation that you describe. What does a society need to believe about itself and about the groups within it in order to produce that kind of weird prejudice, and in order to live by that rule every day? I think that for me, the question became, what's the earliest moment that I can go back to understand points of contact, to see points of contact, to see what unfolds through those encounters? And I ended up working on the early modern period, so for me, 1630 would be like the end point. But not only is there incredible work being done, and that has been done on later periods, but I also want to make sure to say on earlier periods as well. One of the slides I put up, a brand new book that's coming out this fall, Untangling Blackness in Classical Literature, that takes us way back to ancient Nubia. And so I'm excited about what you're suggesting, which is, can we look at the long durée of race and racism and how it plays out in terms of our experiences of access to health? I think that's a fascinating topic, and I think it's one that's seeing a lot of new scholarship, which is very exciting.
Can I fangirl for a moment?
Please.
Oh my. My brain, lots of notes, just so fun. And just in trying to put this together, what your talk did so beautifully was help us kind of complicate and make visible the difficulties, the kind of dialectics, what we assume, what we don't assume, where it comes from, the inconsistencies even in what we take for granted. But there was one point that you made in talking about Caliban that I just want to highlight again, which is continued deprivation by unseen forces has consequences. And the conversation we were having yesterday about structure, right, and kind of the difficulty of kind of grappling with structure, that's another way to make that exact same point. And so my question, I love the pinches and just the connections you were able to make. Where do we take that? Because as you and I said in the hallway, right, that we're having the same discussion, and this is one of those moments where the language we're using by fields is different, but what we're structurally trying to name, conceptually trying to wrestle with is the same.
Yes.
And so what would you say more about that idea that continued deprivation by unseen forces has consequences? And it sounds like what you were showing was Shakespeare, in giving voice to the social climbers, was trying to name what was unseen.
Yeah, that's absolutely the conclusion I've come to, that the reason Shakespeare continues to be a fruitful place of study for me, because otherwise I would leave it to move to other fertile ground, is because it does have this unusual quality of making visible what would otherwise be invisible, of describing systems in a way that not only we can understand, but original audiences in the period could understand and say, yes, I agree, that happened to me, that's unfair. Why is it that way? And I feel like why is the really important question that comes out of the plays for me, is locating those moments where characters, and by extension audiences, say, why is it this way? How did it come to be this way? Does it have to stay this way? And I think when we're trying to expose a structure, what are we looking for? We're looking for ways to, I think the word that was used earlier was measurement. We're looking for ways to recognize it so that we can then, describe its shape, and then we can describe its impacts. But that's very difficult work. It's difficult work in the current moment, and it's certainly difficult in the archive of historical documents, what little we have that's available. So for example, would I love to, excuse me, would I love to go back in time and have a conversation with, black men and women living in London in 1620? Yes, I would. But that isn't possible. And in many ways, what I've heard from you here today is that that's also difficult even now. That having that conversation and that understanding is something that doesn't happen either deliberately or systemically. So the actual lived experience is sort of disappeared, and then we act as if it isn't there. But it doesn't have to be that way. We can discover methods to uncover what's invisible and then address it. Now, the other part of your question, what do we do next? I feel like that's a hard question because you're saying, how do we fix this? And I like the idea that disruption is the place that we start. Because I'm an educator, I like the idea that educating, just talking about, even just seeing some of these images, which for me, as a scholar, had never seen them as a student, like K through 12 student, had never seen an image of a person with black skin before, say, 1950. Seeing those images also has an impact to see a long history and to imagine the experience of people who are long gone. But I don't know that that's sufficient to do what you're describing, because what we want is to effect change. And that's a tougher question that I like the answer that it's one that we're answering together. Yeah.
I have something I'm going to jump in on right before, and then Elle, because it picks up on where I think you and Anna are. So what I was so moved by, and I feel like this is a methodological suggestion that you're making that is applicable across the entire group. You were saying track pain, which I thought was really interesting. Yeah. I've never seen that kind of reading of a Shakespearean text. And so to be tracking bruising and pinching and pain and the comments of the climbers, as you said, right, is not unlike many of the projects that are talking about if you want to identify difference, right, if you want to counter a medical discourse of, well, I treat everybody the same, well, what happens if, as researchers, we track the people who are in pain? Right? Or the people who are being neglected or deprived, right? Yes. The line that Anna quoted, right? So I just feel like there's a methodological move that you're making there that actually does travel across the fields, because I think I've heard the biomedical researchers among us talking about why they're doing community interviews and why they're actually speaking with women, black women in terms of the breast cancer research project, et cetera, et cetera, et cetera. So I wanted to flag that because I was curious about that decision to actually use pain, in a sense, as your data point.
Yeah. Thank you for saying that. I see that connection as well, that if we look for pain, I think the optimist in me imagines that if we look for pain, we will feel a desire to alleviate it. But then what I've heard in this room is that there are other obstacles in place that prevent individual physicians or a health system writ large to address that pain, even when we know it's there. So that's disturbing. But I like the idea that if we persist in tracking pain and if we persist in a listening process, that there is the opportunity for positive interventions.
Mm-hmm. So I wanted to fangirl a little bit too, and I also want to complicate what you just brought up. But the fangirling is that I consider myself a social epidemiologist, and I think you summed up something that is, like, when it comes to race, that is so powerful, where it's almost like a bait and switch, where you create, I can't find your words, but it was in the Caliban discussion where it's like, in that image speaks of it, where you harm this person and you do all these things to this person and then go back and say, this is because of your race or because of your identity. When it's like you create this racialized system that creates this sort of system that creates health inequity, and then you say the inequity exists because these people are black, but those things are like the same thing. Like you make blackness a way of socially stratifying a population, then you say you're in this strata because you're black in particular. Mm-hmm. And that was just powerful the way you framed it, and I would love to reference this when I'm talking about that in the future. The other thing, though, is that our discussion has been, and this is perhaps translation, but it's really deficit space. And the idea of tracking pain, I think that is an interesting method, but that's essentially what we do already when we just measure all these health outcomes and show that Black people are worse. And so like, I push people on this at other places, but we also need joy can be disruption too. Like, I was talking about this in the context of like Black queer spaces, but like, yes, there are health outcomes that are disparate across that group. That is because of social inequity. So it's an inequity. It's not just a disparity to me is like a numerical difference, and inequity is a difference because of lack of justice. But then also there's unique forms of joy that came out of like Black queer movements, like the ballroom scene, and like the alternative family structures that like are lifelines, that are sources of joy, that are places of power. And so we have to make sure because in some ways, if we study racism only from the harms it comes, we kind of reify it, and we're kind of in a way upholding white supremacy, because we're like not looking at the other side of the coin, so to speak, of how like we as people or as racial groups have created unique forms of strength in response to oppression. And so I just want to push us to say, okay, we can track pain, but also let's track joy. Let's track unique manifestations of joy that can only come from being Black, can only come from being Black and queer, and how can that improve someone's health?
I'm so glad you said that, and it was beautifully put. I think that you're absolutely right. I think that the struggle in my field has been to even get scholars to acknowledge this history, that it's present. When I was a graduate student, it would not be unusual for a faculty member to say, oh, you can't study Shakespeare and race, that's not a thing, you can't do that. So that's where we are. But I absolutely agree with you, and I'm excited for the kinds of work that will emerge to explore those moments of joy, because I think they're there. And for me, one of those moments of joy is I've always loved the Renaissance, this time period. Really struggled as a young student that this is a time period that's very ugly in some ways when you think about it from the perspective of the history of racism. But finding a way to do this work brings me joy. Just want to make sure to say that out loud, because, and sometimes I tell my students this too, I'm like, okay, we're going into the semester, it's going to be dark. Prepare yourself. But doing the work, to me, is a way of celebrating this work in this time period, this literature, this artwork, in a way that lets me recuperate something of use and something of interest to me. So, but I'm so glad you said that.
Even that moment of me seeing my work and your work is like,
Yeah.
us, like a shared experience of that joy.
Yeah, absolutely.
Hi, thank you. That was fascinating, super interesting. Thank you so much. It made me reflect a little bit on how important it is, I think, in health research on health inequities to really integrate and bring together the interpersonal, the individual, which is manifested in art in so many ways, with the macro societal structure, economic systems, colonialism, which is shaping a lot of this too, and which had also so much influence on, the economy of slavery and the economic system that we live under, and how it supports and perpetuates and these inequities, right? So I think integrating that is really, at least from the perspective of public health, is really what we really need to do to, I think, both get a more comprehensive understanding of the drivers of racial and other health inequities, and also figure out what we have to do. So, this idea of putting together and seeing the inter-individual, interpersonal in the context of the macro societal, which doesn't completely determine it, of course, and is influenced by those interpersonal things, but has a very strong influence, I would say.
I think what that makes me think of is the particular difficulty of studying in my period, because we don't have access to those interpersonal relationships, or what we have is extremely limited, and it often comes from the perspective of very wealthy, literate, white people, and so it's hard to dive deeper. But what that has meant is that we are doing just what you described, which is to talk about the importance of the connections between the interpersonal and the system writ large by pointing out that we don't have access to the other one, and because we don't, we are missing a larger picture. So in a disciplinary sense, that's what the project has been for some years. But I hear what you're saying, that in our current moment, what needs to happen is the actual marriage of those two, which I have a hard time doing, but we shouldn't.
All right, we're going to take 2 more questions back to back so that then we can give Patricia a chance to respond, and then we'll ease off into lunch.
Just echoing, amazing presentation, super thoughtful, and I have so many things to think about. Something that you said that really stood out to me was this idea of like recruitment into oppression and whether you have the ability to opt in or opt out. And as a social epidemiologist and a person that studies anti-Black structural racism and watching things play out in terms of funding mechanisms and who is getting funding and who is able to go into communities and recruit to be able to do this work on their behalf, is also so interesting to like see those parallels, because I think it reinforces this idea that the racism also within the structure reinforces this perpetual not being able to opt out, right? Like, because you have people who participate in research studies for $50 because the capitalist structure doesn't allow them to have money to eat. And so it's not even necessarily for the benefit of trying to, do research or like whatever, it's like livelihood. And so I'm thinking about the ways in which we can start thinking about how recruitment can be different, not from a place of deficit, but from an actual place of like thinking about how we can move these stories forward with researchers or with communities in collaboration that would actually be beneficial to the community and not necessarily to the researcher.
That's fantastic. Just really interesting. So recruitment is, oh, sorry.
So I probably will disclaim that I'm talking from the science of statistics, right? So there are many different ways to think about measurement, but I wanted to focus on the transition moments that perhaps are going between Ethiopia, dark, black, right? There's a movement between them, and it's that transition that links Negro African to race. All right, so when I thought about this question of health justice, because I want to stay there, the assumption is that change brings improvement. And so you just give me the book. I need the whole reference, because this question of that you can't improve, right, that then takes us right to this question I was mentioning before, that when you consider the racialization of measurement itself, the statistical thing in the 1600s, so now we get racial statistics. And racial statistics is built off of thinking about the body, the largest of the organs is the skin. And so what I wanted to just consider, I have to talk to you in more detail, the question of is not historical only, because it is a system of power that's happening because you're reading wealthy people's understanding of the racial system. And I think that the question of measurement that we see in epidemiology, public health today, is still stuck with the statistical construction of what race is. So we're never going to be able to draw out that tension between the biggest organ that we thought could never change, and we now have to change it, right? Or we have to change what in cases.
That's right. Wow, I could stay in this room all day and I'm really enjoying learning from you. I think whether we're talking about measurement or whether we're talking about recruitment, what's frustrating and what perhaps the early modern period can give us is a confidence in just what you described, that there is a slipperiness between these terms. And any moment we think we're feeling confident about naming the thing and counting the thing, we've already we put a foot wrong, because there's so much slippage between specific terms for describing difference, and then also, as Michelle said earlier, locating difference in one particular type of body versus thinking about, for example, whiteness as the site of difference as well. And I think that's our mission, is to continue to destabilize the concepts, to say when we use specific terms to describe people, specific racial categories to describe people, we are always occluding information. And that is a problem when it comes to providing equitable access.
Thank you. Thank you so much, Patricia. Thank you, everyone. Obviously, keep the conversation going. We're just moving rooms, but shift over to the Christopher's for lunch, and we will see everybody back here at, what's my timing? 12:45. So, thank you.
I think it's officially 1. I think it's 12:45.
Oh, I have it here.
Yes, this one is. It has been such a phenomenal conversation, and we want to keep it going because we've got some more richness to bring to the conversation. So with that, welcome back. Welcome to our live stream guest. It gives me great pleasure to introduce someone to this group. Does not need introduction, but I will because I want to highlight who we're hearing from. So Dr. Perry Halakidis is Dean and Professor of Biostatistics and Urban Global Public Health at the School of Public Health, and he's the founder and director of the Center for Health, Identity, Behavior, and Prevention Studies. Perry is a public health psychologist, researcher, educator, and advocate, and each of those words is particularly meaningful. For decades, his research has specialized on infectious diseases to determine and target the biological, behavioral, psychosocial, and structural factors that predispose HIV, HPV, COVID-19, and other pathogens. This work has further delineated the synergies of infectious disease with mental health burden, including drug abuse in sexual, gender, and racial and ethnic minority population in urban centers. He is currently the dean, as I've noted, for the School of Public Health, and the author of the 2019 book, Out in Time, The Public Lives of Gay Men, From Stonewall to the Queer Generation. His 2013 book, The AIDS Generation, Stories of Survival and Resilience, is a 2014 Lambda Literary Award nominee. Both books received the American Psychological Association's Distinguished Book Award in LGBT psychology. Dr. Halakidis is also the author of Methamphetamine Addiction, Biological Foundations, Psychological Factors, and Social Consequences, and the lead editor of 2 additional books. He's authored over 250 peer-reviewed academic manuscripts and also actively disseminates knowledge to mainstream media, appearing frequently on television, radio, and podcast. And one of the greatest values he provides to us is a significant member of our steering committee, 1 of 6. We appreciate you, Perry. So happy to have you.
Thank you. My mic's on, right?
Yep.
Videographers, I'm going to actually apologize ahead of time because I'm a mover. I don't tend to stay in one spot. It was always a joke. My name in high school, my nickname was the Wanderer because my friends could never find me whenever we went places. Now that I do the math and I calculate, I know why I was wandering. Anyway, so I spent this morning for 3 hours doing press, and both print and news online and TV and radio, and I didn't know if I was talking about polio or monkeypox or COVID or HIV. What I did know in all of those conversations that I had was that there's an emphasis in the media and perhaps in medicine, no disrespect, on the pathogens that cause disease. And I'm here to talk about the other part, the part that's going to be the basis of my next book, which is to think about how people, politics, psychosocial conditions are, and that if we were actually to address the humans who function as these percolators of COVID and HIV and all these other pathogens out there, and the psychosocial conditions and social conditions that place people in these situations, we might not have these problems. But as long as we continue to think that, an HIV positive person who has 3 jobs and 4 kids can take their meds every day without any problem, and having physicians say, well, why aren't they adherent? As long as we have that mindset, nothing is going to get better. So I come to this work in lots of ways. As an infectious disease epidemiologist who's been studying HIV, and now all the rest of them, right, for the last 25 years, and as a public health psychologist. And I think those 2 pieces, for me, in my work, bring together this idea that it is very important to think about the person and the population, and that the best work happens at the intersection of those 2 spaces. And I wrote an article that I'm going to share with you today about the chasm that exists between public health psychology, between public health and medicine, arguing that public health psychology perhaps provides the glue that allows us to address the issues that we're facing in our society. So that's my preamble, basically my talk. I'm done now. No, okay. What do? I press the green thing? Okay, excellent. Okay, so I'm going to start by just giving you my values and my principles, because I think that's really, really important to any talk. Review some of the literature on what we know about racism as one of those structural conditions that fuel these inequalities. Think about some interdisciplinary approaches to addressing this. And if I have time, I'm not swearing I'm going to do this, because, you know, people who know me, and several of you in this room know me, know I meander, right? And I go off on tangents and stories, as they do in my biostats. In my biostats class, students are always fascinated that I can be talking about an ANOVA and then Mariah Carey within the next sentence. So I tend to do that. But I will end by talking about something we did at the Association of Schools and Programs of Public Health, which I'm really, really, really proud of. I think it's really important for me to sort of, at the beginning of any kind of talk about racism, to own my own values and to own who I am as a person. And for me, a lot of the work that I do and a lot of the ways I think about the work that I do is informed by the work of Audre Lorde. And this particular quote here has been very powerful in directing me. And I'm not going to read it to you, I just put it up there for you to see it. But I will read the next one to you, which is my words. I was raised by working class immigrant parents with a grade school education in a home where we struggled to make ends meet. In my 20s and 30s, my closest friends, the ones with whom I laughed and danced, and who were once full of life, died in my presence, while many in medicine turned their backs on us. I have been called fag overtly and in subtle, insidious ways all throughout my life. My program of research has been called niche. Yet, here I am. It would be easy for me to say, if I can make it, so can they. But I refuse to lead with anger and exclusion, but rather with compassion and inclusion to challenge the norms and policies and laws that continue to keep the power in the hands of a few over the many. If it means continuing to take the punches and to be threatened, the punches is an Anna word, it's a battle I'm willing to wage. Because I know all too well the privilege I've been bestowed in our society because I am a white, because I am a man, and because I can pass as straight, I think. I know the privilege of living when the voices of others have been silenced way too soon, and this privilege must be put to good use to stand up for the injustices in society, in higher education, and in all aspects of our lives, and to stand alongside those who too long have been cast aside because they are not part of the white, straight, male patriarchy. And I lead my life every day with this belief. And Anna, more than anyone, knows when I call her with exhaustion about the things that we're facing together. And so it informs not only my advocacy and the way I teach, but the research that I do and how I do it. A couple of years ago, when it was all the trend to put out statements about racism and public health, I worked with folks in the city of Newark and at RWJ Barnabas to infuse this statement as a symbol of what we stood for at the School of Public Health. And for me, as a leader of the School of Public Health, one of the reasons I came here, I think, and it's becoming clearer to me as I enter my second 5-year term, is because I thought we could build something that's a state institution, at a public-based institution that was rooted in activism. And so the school was very much infused with this activist mentality, and it would naturally be when the ACT UP guy is like running the school. And I think that one of our responsibilities as we're teaching our students, whether they be in medicine or in public health or in psychology or in any of the health professions or in sociology or in anything, is to learn how to use their voices to be activists and how to use them effectively. And that's not an easy thing to teach, but it's an important thing to teach, right? So one of the jokes that I made when I first came to the school was, I went to the school and everybody was doing public health behind a computer. And I thought, that's not how public health works. Public health means being out there. Okay, so a lot of what I've written about racism relates to the LGBTQ population. And in this book that Anna so graciously described, there's a whole chapter on racism. Because one of the other things that happened when I first came to the School of Public Health is I wrote this op-ed, it appeared in the Newark Star-Ledger, basically outlining the racist ways of gay men. And I went to work the next day, and people were like, I had no idea. And I thought, how can you think that the gay community, the LGBTQ population, would be any different than the general population? And so when I think about my work, and I think about HIV, which continues to bombard us in our society, which continues to bombard gay men in our society, young gay men. When I think about monkeypox, which we'll talk about today, it is, to me, a manifestation of the racism, the systemic racism in our society at large, but also within the LGBTQ population, which I understand and have studied exclusively over the last 25 years. I also start with these terms that I use to define my work, with systemic racism being thought of as an umbrella term to talk about internalized racism, interpersonal racism, structural racism, institutional racism, and individual racism. That all of these are manifestations of a system of racism that is out there in our society and that we know all too well, that stays silent in our political arena sometimes, right? And that stays too silent in institutions of higher education, where very often policies and procedures which are thought to be an indication of excellence are, in my view, in some ways, an indication of how to keep the power differential continuing to exist. So here's a little bit on the literature. Am I being too heavy? Okay, good. So we know that racism affects health in lots of different ways, and I have lots of different examples to show you, and I don't want to get caught up in the words, but we know that racism affects the individual and the institution. You know, it manifests even if there are no known actors within an institution who actually embody racist beliefs and ideals. And systemic or structural racism within the delivery of healthcare interacts with other structures and systems to reinforce and to perpetuate these racisms, including educational institutions, the labor market, and the criminal justice system. I'm going to talk a lot today about the theory of syndemics, which defines the work that I do. And we spend way too much time thinking about, well, this is what goes on in higher ed, this is what goes on in jails, this is what goes on in politics, but all of these things fuel each other. And if we're going to talk about healthcare and the delivery of healthcare, it is insufficient to talk about it separate from medical education and from the other drivers of racism in our society. I am informed in large part, these are cutting off at the bottom, but I do actually have the citations, so you have these. I am informed in large part by this idea of fundamental causes that was first postulated, described by Lincoln Phelan, who argue that social conditions are the distal factors that cause people to place themselves at risk. So, let's go to HIV. That's something I know really well. Young gay black men don't want HIV. Young black trans folk don't want HIV. But social conditions get them to HIV. And what are those social conditions? And so we can continue to say, oh yeah, HIV is a biological phenomenon, we're going to put people on PrEP, or we're going to have undetectable as untransmittable, or we can deal with the fact that young black gay men are often choosing partners who are also black, who are also more likely to be infected, and they're not having more sex than white gay men. Yet we always come back to this notion of behavior and the person because it's easier in some ways to address the person than the structure and the system. Right? So my friend Ron Stahl, who did HIV work for a really long time, often talked about HIV in the form of like people swimming in a pool of viremia, right? And I think when we talk about that, it's a concept that applies to COVID, that applies to monkeypox, that applies potentially to polio. We'll see. I don't think so, but maybe. And you know, and early in the COVID pandemic, I would get these. I would have folks call me for interviews and say, well, "Why are black folk being affected so badly by COVID?" I'm like, "Why are you surprised this is happening?" The same sort of structural inequities that fuel every health disparity are at play here, right? If you have not seen David Francis is a documentarian. He wrote and produced an Oscar-winning, Oscar-nominated documentary, How to Survive a Plague, where he basically went and found all the VHS tapes from the ACT UP days and created a documentary of how ACT UP addressed HIV. But he made a film last year called How to Survive a Pandemic, where he applies some of the concepts of the first plague film to the COVID pandemic. And he actually follows a set of folks outside Philadelphia dealing with the black community around vaccination and around dealing with COVID. If you haven't seen it, I think it's on the HBO Max or on the Hulus or on one of those things. One of those things. Hey, look, when I grew up, it was 2, 4, and 7, right? So there's like a lot of choice now. So racism is one of those fundamental causes. And if we think about it, right, we see racial differences in health outcomes. And my friends at my table yesterday will note that I stated one of my favorite commentaries is by Lisa Boleg in the American Journal of Public Health, where she says, sure, we can continue to document that race is a factor that explains the health disparity. I don't want those articles. I want to address the systemic, the causal factors that create those inequalities, right? And I think this is a really key moment for us, right? It's because I'm giving a talk at the University of South Florida in a couple of weeks where I'm talking about we're needing to shift the dialogue from health disparities to health equity. Because one is about documenting, and we can keep throwing our hands up in the air and saying, oh, yeah, okay, differences. Or we can be thinking about interventions that ameliorate those differences or lessen those differences. And those interventions are person level, interpersonal level, structural level factors that we have to address. Okay, so we know that some of those structural factors are things like racial segregation, right? And we know consistently from the literature that separating neighborhoods for people of color from white people results in more limited access to care and services which are not predominantly white affecting health. We think about what happened with monkeypox a few weeks ago in New York City. There's clearly this lack of vaccination, lack of vaccine available to young gay and bisexual men, or at this point we should be just vaccinating everyone, frankly. And so, like, people like me we're saying, well, you've got to bring the vaccine to folks, right? You don't expect folks to come to you. People have jobs and they can't travel. So they were like smart for a minute, just a minute, not 2, and they said, okay, we're gonna do a vaccine thing in Harlem, right? Okay, but here's the problem. Nobody checked residents. So all the white gay folk went up to Harlem to get the vaccine. And when you looked at the line and the pictures, and I think I might actually have a picture of it, you saw that the young gay black men who were living in the neighborhood were not on that line, right? And that disparity manifested in other ways. So here's another version of that disparity and talk about the structural stuff and why it's not enough just to talk about one institution separate from another. There's no vaccine to be found. Yet somehow, now how many of you are familiar with something called Fire Island? Okay, so y'all in New Jersey have something called Asbury Park, but it's not really the same thing. So Fire Island is this barrier island off the south coast of Long Island. There's 2 towns called Cherry Grove and the Pines that are predominantly these havens for like LGBTQ people, right? They're beautiful. They're freaking beautiful. And so I'm lucky enough to be able to be there in the summer. My part of the Fire Island, mostly white, older, gay men with money and power, who are not out dancing every night, because who wants me in the club, right? I mean, ice cream at 7 o'clock, watching Shameless with my husband and the dogs in the bed. We're all good. We're all good for the night. That all of a sudden, miraculously, there was a vaccine for us. And not only was there a vaccine for us, vaccine came to us. So here, to me, is yet another things we have to call out, which is another example. So who's making that decision? Some healthcare system? Some DOH? How is that relating to the federal government? Right? And these conversations around those things, to me, have to be elevated because they are a manifestation of this racial segregation. Now, Fire Island's trying really, really hard to be more integrated. They're trying. If you want actually a bad movie to watch, which manifests, it's called Fire Island. It's on the Netflix, right? It's on the Hulus. It's on the Hulus. Okay. So here is another example of racial segregation. I've been talking about a lot about infectious disease, but here's another example. There are several studies that indicate that segregation associated with low birth rate and preterm birth for black moms, and that numerous studies have demonstrated elevated mortality and lower survival rates for breast and lung cancer for blacks due to segregation. And if you look at these maps here, what you tend to see, this is the New Jersey thing, what you tend to see is the mapping of maternal and child mortality to neighborhoods that are predominantly black, right, that are not here, not in this red part of the state, but in the centers, in the urban centers where folks are poorer, where folks tend to be black, and as a result, we have these outcomes. Here's another example of my hometown, New York City. Are those somewhat clear? They're clearish. You'll see them better when you have them in person. Here's another example. This is showing a geographic distribution of HIV, right, in the city, and then HIV diagnoses, and then mortality on the far right there, the green. And what you're seeing, for those of you who are not aware of the New York City map, so this is Manhattan, Brooklyn, Queens, the Bronx up here, that Staten Island thing here, right? And so what are you seeing? You're seeing a lot of HIV, like in Upper Manhattan and in the Bronx and in Chelsea, and these are predominantly gay areas, right? And in central Brooklyn here. But what you're not seeing when you look at deaths is the deaths in the white neighborhoods. So HIV positive people who are white, who are living in New York City, who are living in neighborhoods like Chelsea and Greenwich Village are not dying at younger ages. But black folk and poorer folk who are living in these outer what's called the outer boroughs, in the South Bronx, in Upper Manhattan, in these parts of Brooklyn are dying. Racial segregation. Here's work from our own study that I worked on called the P18 cohort study. We were funded by 10 years by the NIH, where we followed young sexual minority individuals over the course of their emerging adulthood. And so they started at 18, and we followed them every 6 months for 14 waves of data collection. It's like a huge, huge, huge data set. Stephanie knows, she's worked on this study. One of the things we did was we were trying to look at the drivers of HIV in the population. Okay, so we started with 600 18-year-olds who identified as having sex with a man. Identity was not important at that point because, you know, it changes over time. 594 ended up being negative at baseline. And then we followed them over the first 7 years and found a cumulative incidence of 7.2%. 7.2% of those 594 seroconverted over the course of what was 36 months. That's between 18 and 21. So, and when you look at all of the participants in the study and the seroconverters, what do you see? You see black men, mixed race individuals, and then poor individuals more likely to seroconvert. And so, oh, they must be having more sex, is often, I don't know why I go to that default voice all the time. I think it reminds me of my uncle. It's my Uncle Nick in my brain. It's him, right? God bless you. All right. And you would say, oh, they're having more sex. But in fact, when you look at the data in this study, and you look at having unprotected anal intercourse, which is the riskiest of behaviors for the acquisition of HIV, the white guys, like 21% of them are having it consistently, whereas only 15.9% of the black guys are having it. So it's not just about behavior. And Greg Millett and others have done a really spectacular job at outlining all of this. But what is clear when you look at this, one for example, is that the folks who are seroconverting are from areas of the city where there is higher viremia, where there's more undiagnosed, untreated HIV. And so, fill in the blank. It could be COVID, it could be monkeypox, it could be HIV. If you are navigating a space that is viremic, you're going to get sick, more likely to get sick. And so, to me, this comes back to this idea, again, that folks are embedded in a context, and the structural elements of the context are perpetuating the racism and the segregation which are fueling these health disparities. Okay. There's also this notion of cultural racism, which is another factor that is very much at play in terms of perpetuating the health of the black population and other racial and ethnic minorities in our country. And it's basically the installation of the ideology of inferiority in the values, language, imagery, symbols, and unstated assumptions of the larger society. Okay, I'm going to do a sidebar here. This is kind of like the same thing we face in higher ed when people say, oh, they do community-based participatory research, as if somehow that's lesser. Oh, they don't publish in a journal that has a high impact factor. They just sort of write newsletters and other things like that, as somehow those things don't matter. And so I'm putting this in your brain because you're all like academic leaders. Like these are the battles we should be fighting in our institutions, right? Because if we're going to continue to like talk about like impact factor and RO1s and things like that, that's a manifestation of this. Very, very, very much. Are you snapping in? Yeah. Okay. Okay. Good. Good. And Anna knows I fight this battle every single day. And sometimes I feel like I have 10 heads when I'm talking to people. But it's okay, it's fine. You know, the idea of cultural racism is, you know, based on this notion of the stress that is created in people's lives, that creates these vulnerabilities in their lives. You know, in this endemic model, which I'll talk about for a second, it's called psychosocial conditions. Ilana Meyer calls it minority stressors. And all of these factors place people at risk. There's also evidence of discrimination, which leads to these psychological states, which leads to these physical manifestations of these health outcomes. Right? Nobody wakes up one morning and says, I know I'm going to have a meth addiction, or I'm going to acquire HIV, or I'm going to have cardiovascular disease. Nobody does that. Nobody wants these things, right? Circumstances, life conditions, social, political factors get people there. That's what's driving these. So what am I trying to say here? What I'm trying to say consistently, and what I'm trying to do in the remaining part of my career, whatever's left of that, is to elevate the conversation and fight it up here at these macro structures. Because I think we have spent way too much time focusing on the individual, right? And unless we are willing to go up here, and this is hard, right? This means we've got to get politicians to actually believe this, right? And we have to actually ask politicians recognize it's going to be much more expensive in some ways. We're not going to change anything, right? It's just going to continue to perpetuate. Here's some more facts, and Juana knows this probably better than anyone in the room. In New Jersey, we're 47th, has one of the highest rates of maternal death in the country. That's ridiculous, considering how rich the state is. The rate of women who suffer from severe maternal morbidity in New Jersey is, as compared to others, is 50 to 100 times greater. And in the state of New Jersey, the rate of black women dying compared to white women is 4 to 5 times greater. So, another manifest, like we could fill in the blank. Choose your disease. It's like the same pattern. I really can't see this at all. You will see them when they're on the slides. This is basically from a paper that was published by Paradis in 2006, where basically we show very consistently here the positive association between self-reported health and racism. So like more racism, more negative health outcomes, less racism, better health outcomes. And it's the paper cited there, so you can take a look at it. And here's the monkeypox thing. Just, you know, like timely, like in this moment, look at this chart. Look at this chart here. Look at the percentage of monkeypox cases, right? And percent of the U.S. population. You know, black men are 13%, but they're 27% of these cases. It's like, look at the white guys, right? White guys are 59%, yet they're only 37% of the cases, right? So here is something that's happening in real time with real people that continues to evidence here. And part of it is about words. One of the interviews I did this morning was about the term monkeypox and by how we have to like think about a different term for it. And they're working on it. And words matter, right? It's sort of like when I scream at people and say, I'm not an MSM, I'm a gay man. Stop making me an MSM, which is a vector for disease, right? It's not just about my behavior, it's about my identity. This word matters, because this word has connotations that imply Africa, that imply chimpanzees, that imply it must be something about race that monkeypox is all about. And so we're working on that. The other thing that we know from the literature is that racism is evidenced in other forms of health outcomes, including firearm violence. And if you look at this is a paper that looks at the correlations between firearm homicide rate and characteristics of a neighborhood, right? And you see pretty consistently a very high correlation, 0.71, between the black population and firearm violence, right? You know, single child households, right? And all of the factors that describe, you know, unemployment rate, you know, poverty, all of those factors, all of those characteristics, race, by poverty, by neighborhood, by location, are associated with this increased violence and firearms, okay? And here's another actually really cool paper that this is Louisville, Kentucky, and this is based on a sort of an analysis of the city looking at social desirability. And what you see pretty consistently here, and it goes from A, grade A, highest real estate social desirability, to D, lowest grade, you know, pretty consistently that the gun violence was much more associated with neighborhoods where there was lower desirability. So here's another part of the equation, real estate, home ownership, right? That also plays out here. I did a study, part of the P18 study. We also did a sub-analysis with a colleague of ours called Maria Kahn that looked at stop and frisk in New York City. And very consistent with what I just showed you about the real estate, that in neighborhoods that were less affluent, right, in which black folk and Latino folk were more likely to engage gay folk, there was more stop and frisk incidents than there was in other neighborhoods. And in fact, if you look at the data, here's a bunch of odds ratios. Not only did we show that it was that black and Latino young gay men were more likely to be stopped and frisked, but also those individuals who were stopped and frisked also had a series of mental health conditions and psychosocial conditions that were higher than the rest of the people in our study. So they had higher levels of PTSD, as we measured it, higher levels of depression, higher levels of anxiety, and more internalized homophobia. So the internal factors perpetuated by the external factors leading to and coupled with the neighborhood people are living in, leading to stop and frisk. Okay, so there have been several efforts to try to advance the science around racism and health, and part of it has been directed by my friends in psychology. Right, and so I'm going to give you a set of suggestions that come from this Neblet article that I think are really interesting for us to consider and for you to consider in your research. Measuring racism. So one of the recommendations is that we undertake behavioral and psychological studies that examine institutional, cultural, and structural racism and their impact on health. Measures that are not exclusively mediated by the individual. So how are we going to effectively bring all those macro factors into our research to demonstrate their association with poor health outcomes, but then to take that immediately and to translate it to intervention? Number two, developmental health. It is not sufficient to think about the effects of racism on health the same on a 5-year-old, as a 15-year-old, as a 25-year-old, as a 55-year-old, as a 75-year-old. And so the second recommendation for research in this area is to think about the developmental stage of the person, where the person is in their lives, and how racism and all the forms of racism are affecting that person. We know perfectly well what happens in 0 to 5 affects lifelong realities. We know that, right? But it doesn't mean it stops, right? Number three, one of my favorite things, resilience. So every public health model you see out there, including the HIV work, is about what people do wrong. They don't use condoms. They use meth, right? They have lots of sexual partners. What are people doing right, right? Because for the 20% who are not using condoms or who are on PrEP, I mean, it's a very old school of me, condom abuse, but I'm going to stick there. 80% are. What are they doing? What are the folks who are not relying on substances doing in their lives to allow them to be able to deal with their realities? So that's flipping it around and saying we're not focusing on deficit, we're focusing on positive aspects. It's a positive psychological way of thinking about things. And in fact, my colleague Kristen Krause and I have developed this very simple model. It's nothing complicated here. There's no progesterone decremented. You know, it's like a very simple model here that basically says the following with regard, this is based on our work on older adults living with HIV, which, as you know, in the United States, is the majority of people living with HIV are over the age of 50 now, blah, 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 right? But what we believe is that if you look at the realities of HIV coupled with the aging process, coupled with these structural and social conditions in which folks who are living with HIV face, which is often racism, homophobia, poverty, right? All of those things, transphobia, all of it, that those things together affect the health of a person. And in my mind, and I said this at our table yesterday, you don't think about physical health separate from mental health, separate from social health. In fact, I'm always the guy at the table who says, when they say mental health, my response is, you mean health? Like health. Right? Why does it have to be mental health? It's sort of like, why does it have to be community-based participatory research? How about it's just research, right? Why do we have to other it, right? So by thinking about health, so we did this, and we postulated this, and then we collected data, really amazing quantitative data, but even more beautiful. We did this in Newark 2 years ago, right before the pandemic, 50 interviews with male and female identified people living with HIV from Newark. And the stories are rich in how they understand their resilience and how they got to their resilience. So here we go. They can articulate, these wonderful people can articulate how they think they're coping with all of this. Use it to develop models. That's what I'm saying here. And so this was it's a series of studies called GOLD. But this is just the demographics on that study. And what we saw pretty consistently is that people who had higher resilience had no symptoms of PTSD, lower levels of depression, lower levels of suicidality, less substance use, and less generalized anxiety. So somehow, maybe, what the mechanics were, resilience, which I would argue is kind of a trait and kind of a process, maybe both things. In the chapter, I describe it, I think, as, you know, as a muscle that you can grow, potentially, or make stronger. Resilience acts as a protective factor against these outcomes. So, if it's acting as a protective factor against these outcomes, then how do we embed it in both interventions, but also the delivery of care, right? Like, how many of you go to your doctors and they ask you, what's going well in your life? What are you doing right in your life? They always ask us what's wrong, right? What hurts? You're not doing drugs, are you? Right? I mean, I can hear it in my brain when I see my doctor, right? How many are asking, what's working? How are you? I see that your body looks really good. I'm looking at myself and my body dysmorphia is kicking in. I see your body's looking good. What are you doing to stay in shape? Right? Those positive things that I think are really an important part of the conversation. My parents, and I'll show you the American Psychologist article, my parents both died because they were afraid to death of doctors. Right? My father died at 57 years old, 2 years younger than I am right now, because his stomach hurt, and he had ended up having stomach cancer, and by the time it had exploded, the tumor on his stomach, it was too late. And because he had this fear of doctors and the way they talked to him and the power dynamic. The same thing with my mother. My mother died at 76, slightly older, but the same thing. Avoidance of doctors because of fear, because of what the doctors might say. And they're like these white immigrant Greek folk, right, who the healthcare profession has sort of forgotten how to talk to. And so they died. And they could have probably been still alive torturing me as we speak. Okay, and that's where I write about that in this article here, where I encourage you, if you have a chance to read it, I can make it available to Anna and share it with you, that talks about the need to actually deal with people's fears and anxieties and the things that they're feeling about their health that are really important, how public health psychology has a role to play here. Finally, the last suggestion in this really cool piece that I read was about the need for education and training. Right? And what do I mean by that? What is pretty consistent here is that we have to have at the table folks from various disciplines working together. We talk about interpersonal education all the time, but we don't really live interpersonal education. We do when we're out in the world, but we don't teach our students how to actually do research that is based on interpersonal education, that brings together the social worker and the artist. Like, one of the really cool things we're doing at the School of Public Health is public health art. like artistic expressions of public health issues. Yeah, duh. I mean, the arts are always ahead of science, right? The movies about HIV are always ahead of the policies around HIV, right? It's like, art is always cutting edge. And so if you bring art and science together, art and public health together, maybe it advances us and allows us to think about the way we're doing things in different ways, right? Not in the traditional ways. Okay, so what we did at our school, because I think education is a big piece of this, is we wanted to really think about how we were teaching our students. And so we took it upon ourselves to do this assessment of our syllabi. People were panicked. Everybody was freaking out. It's not part of your evaluation. It's all fine. This is a reflection. And so what we did was we developed this assessment, and every single person who was teaching had to do this assessment on their syllabus. And essentially, we asked them to think about these various terms, to think about all these factors, and I'm sure we've missed some, of diversity, equity, and inclusion, and then to basically to go through their syllabus and to identify how their assignments, their guest speakers, their lectures, their readings, their examples were indicative of diversity, equity, and inclusion. So one of my favorite conversations that I teach biostats, which is the best 2 hours of my life, always, every year, is when I do analyses and I'm like, and I have them read papers and I'm like, here's the differences in the intervention based on race. There's black folk and Latin folk and white folk and Asian PI folk and this other really cool race, the other. And I'm like, what the hell's that? Right? And how many of you read those papers that have this other? Who are these other people, right? And yet they are published. And to me, that is a great learning moment in the classroom of how this term is sort of a diminishing of people's identities, right? And it's mind-boggling how the students actually leave that discussion feeling like, wow, I never even thought about that. But go pick a random article out tonight, and you'll see the others there. They're lovely. They have great folk songs and costumes, the others. And so everybody did this, and then we did an assessment, and then we reflected back. There are several frameworks that can be used to define our work around racism and health. How am I doing on time? I'm good? How many? Okay, great. I'm sharing a few of them with you, looking at health outcomes, but again, talking about the pathways. I think pathways is key here to our work in addressing how racism affects health. Not outcomes, not disparities, pathways. All right. Here is another model. Racism contributes to and perpetuates the economic, financial inequality that diminishes prospects for population health improvement among marginalized and racial ethnic groups. Another way of sort of saying the same thing. Another visual here. We know that there are complex interactions of family, community, culture, and the need to correct structural inequality which address these outcomes. For me, and this is my table again, I go back to so much of how I think is about this 1977 article by George Engel, about the need to move the conversation from biomedical to biopsychosocial, to recognize that the patient is more than a vessel for pathogens, that the person has these psychological realities, these social conditions. And we talk about, the nurses get this, right? We talk about this in medicine, but it doesn't always manifest that way. The other thing that has informed my thinking over the course of the last two decades is this idea of a syndemic. And for those who are not familiar, I'm sure most of you are, the idea that one health problem is not separate from other health problems. Where you see drug addiction, you see mental health issues, you see obesity, you see tobacco use, you see HIV, you see violence, you see interpartner. These things don't happen in isolation. And even more, they synergize, not really a verb, they interact, they fuel each other, they catalyze each other and make things worse. At the beginning of the pandemic, which pandemic, you might ask? The COVID-19 pandemic, that one. Stephanie Shao, who's a colleague of mine, and Kristen Krause and others, wrote this article that's been like a winner for us, which is it's just a visualization of COVID-19 in the context of everything else. So we had this model before, right? We were talking about HIV, substance use. Those of you who do HIV work know that this is a very common way of thinking about it, but put COVID-19 in there too. And this is just a way, I think, for us to think about how all of these factors, minority stress, misogyny, homelessness, all of these factors interact, right, to fuel each of these, which, by the way, interact and make each other's worse, make each of the others worse, but also can be perhaps ameliorated or softened or be less harmful if we think about strength and resilience. Maybe. The other way we think about it is this urban public health paradigm that we have been pushing at the School of Public Health, which essentially says that in order to be able to enact a change in the well-being of people and populations, right? Because we have to think about both people and populations. And this is the the dichotomous part of me. Like the psychologist in me wants to say people. Like what does Johnny need? And the public health person in me says the populations. What do the Greeks need, right? But in fact, it's people and populations, right? And too often we ignore one. Right? And I'm going to keep pushing us to keep thinking about both, right? I don't love the word population health for that reason. I mean, I wish it was people and population health. I don't know. I actually just think it's public health, but okay, don't tell anybody. But I think that in order to enact those changes, yeah, you need an academic healthcare industry, healthcare system, absolutely, as we have here. Yeah, we need city government. What's often forgotten is the people who know perfectly well what they need and can tell you what they need and how they need it and what they're feeling if they're given a chance, and business. And I think, when I think back about COVID-19, and I kept thinking, oh my God, why are those sites crashing? Why haven't you hired a 12-year-old from Amazon to program this, right? Like which 59-year-old did it, right? I can barely use my phone, right? It's clear to me that we're not tapping enough into industry and what industry can offer us in advancing our medical practices, our public health practices. They understand people and consumers in a way that most academics, I think, do not. And so I see that marriage as really, really clear. Now let me tell you my little dream and secret of what I'm going to accomplish in the next 5 years. I have this vision in my head. It's based on Halston's Atelier. Was that the gayest thing I ever said in my life? Halston had this space in New York City where people would just come. He was a designer who would come. If you haven't seen it, Netflix, amazing. The Netflix. Halston had this place where he would design clothes, and there would be movie stars there, and people would come, and they would think, and they would do designs, sort of like the Andy Warhol space too. Also a great documentary on the Netflix. So I have this idea that we're going to have a space at some point at the School of Public Health, somewhere in Newark, in one of the wards that is underserved, that's going to have this community space for people to convene, this accessible street-facing clinic where people can come get services, with a school above it where we can train people from the Department of Health. And there's going to be this big buzz going on where the students are going to be working with the people in the community who are going to be working with the clinicians, and it's going to be real. How real people operate. And you put it in a physical space that allows all this hustle and bustle to go on. That's really exciting. The CUNY School of Public Health has moved itself up to Harlem in part to try to do that. I don't know if they've actually accomplished that. I think we can do it in Newark, right? And I think that it will be a place that will empower people from the population, from the various communities within the population, to come and be part of the conversation and to help us think through, hey, what do we need to do? This is what I love about the David France documentary. What do we need to do to get people to want to actually take vaccine? You're talking to your friends. What do we need to do to get people? How do we help young black men put their resumes together so that they can get a job, right? Because that's part of their health too. I think CV building is very much part of a person's health. You help them get economically, bolstered, right? The outcomes are going to be better. But this is the kind of thinking we need to do, right? That means that we have to then challenge the racist beliefs that continue to perpetuate in our society, which are black folk do bad things, and as a result of that, that's why they have these health outcomes. How much time about? 1 minute? Okay, so I'm going to just show you one thing, one picture, and then we're going to have a huge conversation about this. And Ella's going to ask me really hard questions. One of the great things I had a real privilege to be part of was, one of the things that I have great privilege to be part of is being part of this Association of Schools and Programs of Public Health. And 3 years ago, we put out a statement on the need to dismantle, how do we address harassment and discriminations in institutions. And we advanced that. And then we thought about, well, we should take this framework and advance it even more. And we put together a framework on dismantling racism and structural racism in academic public health and what schools and programs can do. And these are my colleagues, but very briefly, I just want to show you that if you're interested, and this is available online, what we came up with was a way of thinking about how to address these issues across 3 areas: education, practice and service, and research, because all matter, and across these 5 populations: faculty, students, staff, the populations we work with, and the public health workforce. And what's really great about this document is that we have intermediate, and long-term strategies that people can implement in their schools and programs that allow them to address some aspect of this. And we're following now how each of the schools and programs are developing these strategies to address this. So on that note, thank you very much.
Don't go anywhere.
I'm not going anywhere. Having a sip of my Diet Coke.
Please sip. So we're ready, right? So I just want to give you a prelude of the conversation, because y'all know we've been going at this strong all day. So we're not going, the conversation is in nowhere ending. We're going to be here for about another 25 minutes, so get your questions ready. We're going to transition from this into the clusters. Because the promise from yesterday was that that was kind of the beginning, foundational, and then we were going to go back to the clusters to continue the conversation. So take this as the beginning. We're not going to get to all of the questions, but I want to get us started. Candace is the mic. We had a question over here. Oh, no, we've got one first. Go ahead. Take it away, Al.
I don't know why you picked me out to have hard questions for you, but it was not wrong, I don't think.
Because I'm a good read.
I want to talk a little bit about resilience and also about syndemics.
Yeah.
So I am wary of the resilience as treatment paradigm. It's something I've been writing about right now. And I have a lot of issues with it, but I'm going to try to boil it down to just 2. Resilience isn't actually, if you look at how, it's not actually expected the same way of everyone.
Correct.
We often expect black women and black people to be resilient. And so anything that is a treatment that is only expected of certain people, I have questions with. We think about that as superwoman syndrome and things like that. And also, more importantly, it's a fundamental mismatch between what we're trying to solve. Resilience is an individual thing, and we're trying to solve structural issues. We only expect people to be resilient when it comes to dealing with poverty. We only expect people to be resilient when it comes to dealing with racism. And I think implicit to that is that because the alternative is to have deep societal change that changes those structures, and it's easier to put that on the individual to be resilient. And so I want to push against, and the last thing is that resilience is an adverse event. You can only be resilient after you've been harmed. And so in what other place do we think of adverse events as treatment? And I don't think that is something we should frame it as. And the other thing I want to talk about is syndemics. And
Can I try to address some of that? Because I don't disagree with you. Yeah. So I think that, the term resilience is often used as a catch-all to address people who have been in difficult situations who have to develop tools to survive, right? Mm-hmm. And there's individual and there's community-based resilience. My point in pointing it out here and what I believe is people have strength, though. Communities have strength. People have strength, and we never talk about
And I think the strength stuff is actually a different thing.
Yeah,
I think
the resilience
isn't a response to harm. It's actually building up prevention from harm. And so I think those are very different things. And I think we have to, at least how they've been implemented. I'm not a terminology person to tell you what words to use, but resilience, how it's been implemented and what is expected. If you think about the educational, we want our physician trainees to be more resilient. So we don't change how the fact that the reason why most doctors are committing suicide, suicidality is super high amongst physicians, is because we brutalize them during training. And so the response is we need to find ways to do resilience trainings. You can't train an intrinsic trait, and that is not changing the structural elements. And so the other thing about syndemics is I'm not just wary of stuff, y'all. I've actually aware of solutions to these things, and we just talked about one. But the syndemic sort of model, which came out of medical anthropology and Meryl Singer, has been bastardized a lot in public health. And so the distinction between disease processes and the social structural factors that facilitate them has gotten hairy. And so in my conception of a syndemic, what I think was close to the original is that we have synergizing disease processes that are facilitated by social structural things. And people have started to lump the social structural stuff into the syndemic. We have a syndemic of poverty and HIV. And I'm like, poverty is not a disease process.
Right.
That is the structural thing that facilitates HIV and TB and these other things. And so what is my question to you is because I think there's a lot of utility in the syndemic framework, but it becomes just window dressing and meaningless when we start to do that overlapping. So how do you respond to that misuse, in my opinion, of the framework? And what do you do to prevent that?
Well, so here's how I respond to it. I agree with you 100% that I don't think that poverty and misogyny and discrimination are part of this endemic. I think the health outcomes in the original conception, when you read the 1994 Meryl Singer article about HIV in Latin women, is all about disease states. How I address it is when I read papers for my journal and I read grants and they have it there, I say it's wrong, right? It is wrong, right? And I psychosocial drivers and social structural drivers are the antecedents, right? Weight, cigarette smoking, HIV, that's it. So I think we just have to keep pushing that, because that's I think what we show in there very clearly, that these things are the drivers of the disease. That's how I address it. I'm with you 100%. It's like bad telephone has happened between that 1994 article and 2022 and syndemics, and somehow it has gotten changed in so many ways. So keep pushing back. Anne.
Yes, so with regard to that comment you made, it may interest you to know I'm starting the business school on the 1st.
Excellent.
And it's interesting that Elle brought up the question of resilience, because that was actually my question too. Despite what was just said, I'm very curious to hear how you measured or how people were talking about resilience in the paper you cited.
In the qual paper? Yeah. I don't know, because we're just analyzing it, but I'm happy to be part of that conversation if you want to, because we're always looking for collaborators, and we've been sitting on that data now for 2 years, so we should talk. I mean, these interviews, we were able to fill, we were going to do 40 interviews, and we ended up doing 50 because the folk in Newark, within 8 days, had signed up to tell us about what they thought about their results. And one of the things I can tell you, Anne, that's really clear, though, is that that's not a word that a lot of the folks were actually using. They were not saying, I don't know what that is. They were like, I don't know what that is. Right? I can tell you that I just wake up every morning and I take my pills and I keep them in a container and blah, 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 blah.
Yeah, so, this is something I find so interesting, because one of the things that Perry probably knows, and probably nobody else does, but several years ago, I led a study looking at stigma among people living with HIV in New Jersey, and we did surveys of I think it was 371 people throughout the state. And the model was you train people living with HIV to interview people with HIV. And the reason we did that was because there was this idea that people living with HIV were being stigmatized by healthcare providers. And that was the main impetus for doing it. But when we did these interviews, one of the questions, and it's about how you ask the question, the time frame of the question, all that stuff. But when we asked people, in the past 12 months, have you felt stigmatized by a physician? It was 20 out of 371 people said that. And for all the other health professions, it was less. But in the qualitative section, people said, oh, I felt stigmatized by the dentist when I was first diagnosed. And these were people who were diagnosed 15, 20 years ago. And how that stays with you. And what do you do about that?
What I love about your comment is, Anne, is that, I think very often, and I try to tell this to my students when I'm working with them on their dissertations or on their research project, is the words we use. How many of you have faced stuff in your study where you measure race and ethnicity and the Latin guys just told you, I already told you I'm Latino. Why are you asking me what my race is, right? When we use words like stigmatize and resilience, and we just assume that everybody and their mother knows what those words mean, we actually push our participants away, right? And so that's why I love the mixed method stuff, right? Because the mixed method stuff manifests it. And we have to think, and I think the other thing that I would say to you is that when I teach the survey design course, I talk to folks about how do you take regular sentences that people use and make them into questions on a survey instead of the words that we use every single day in academia. Yeah. I love this conversation.
you so much for this talk. I had a question about your beginning. You were talking about like the activism approach and sort of the public health education. And I'm just curious if you think there's space for abolition movement in public health education versus activism. So I consider myself an abolitionist scholar in the idea that I feel like we could completely reimagine what's happening and not just necessarily creating policy, especially around the resilience question, to mitigate what is happening, because that usually gives space to create something different that could also harm communities. So I'm just curious what role you think abolitionist movement could have in public health education.
I'm always about tearing things down and building them back up again. I mean, I think that look, at the end of the day, what we do and what we've done in public health and in our schools is like we've patched these things together. So we started out with this like set of courses, and now we've like put everything on it. But I think the notion of tearing everything down and starting from scratch is what we're trying to do with the Association of Schools and Programs in Public Health. So here's an example. We could have a racism in public health course at the school. Sure, easy. That's the easy way out. Or we can assure that all of the core classes read a set of articles about racism, and that you think about it from an epidemiological perspective and a biostats perspective and a policy perspective, and that's much more difficult. And that means tearing down what we have in place right now and rebuilding it. So I think there's lots of space for that. Thank you for that comment.
All right, my question, well, more of a comment than a question. We're talking about disruption here since we're being here, and your point about racial residential segregation is an important mechanism as it relates to health outcomes. But I struggle with racial residential segregation because it's often about tapping into the distances between racialized bodies. And so what would be the disruption? Is it integration? And if it is, integration whom into where, right? So is it black folks got to be integrated into white neighborhoods to make things better? Or is there a question about investment, right? There's a kind of possessive investment in whiteness in the United States that's often not explained in the same way when we talk about segregation. So I'm really curious about how we think about segregation. So we can talk, like many studies, and Ali has a paper, Black Box Segregation, shout out to you, that's really, really good. And I really, in the work that I'm working on in terms of the notion of racialized space, that how do we invest in spaces that can have positive outcomes regardless of segregation. So is segregation really the mechanism that makes these health disparities possible? Or is it the space? Because I make the argument in my work that space is a race-making process. And so when people talk about racial residential segregation, my fear is that there is an assumption that to fix black folk is to put them into white spaces. Now, I'm not saying that you're saying that, right, but it's often this kind of taking for granted notion when we're talking about racial residential segregation.
Yeah, no, I agree with you. I think that it's not about desegregation, right? I think it's about economic equity that allows people to navigate spaces that are their choice. But two, the other thing that the other issue that you raised, which is investment, right? And it comes down to economics, right? So, you know, I mean, I grew up in the 70s when they were like busing kids all around, right? And I just want there to be like really, really, really good schools in every single neighborhood. That's, to me, the solution.
Is this
Yeah.
on? Okay. I'm Maxine Davis. We haven't met, but I'm in the School of Social Work. I'm new faculty there. I'm going into my second year.
Welcome.
Yes, and first, I'm glad that you're leading our School of Public Health. From this presentation and the conversation that you're purposeful about having. So thank you. And I'll tap you. Don't worry, you're gonna hear from me. I have one word that connects a lot of what I've been thinking across this session particularly. It taps into Ali's comment on it all comes back to money. It taps into Elle's comment on healing, on resilience and from my view, healing practices that are individual but also communal. It taps into getting at structural changes instead of individual, and that word is reparations. For reasons that I've observed in the literature, but also from my own lived experience. And I think that is a policy level intervention that would impact health in a positive way for a number of reasons. And I also want to emphasize that healing for people who have experienced racialized or gendered trauma, but specifically racialized trauma, is not a one-size-fits-all. So for me, finding the right Black therapist, the right one, because we went down it took a while to get there. But then also engaging in therapies that were specific to what would help me bring my voice back, which is music therapy and vocal lessons. That's where I had to spend money, over $4,000 that I didn't have in order to fix the racial trauma I experienced in academia before coming here. So that is one comment, okay? The other comment, and it's the person from our WJC, the other part is investment into institutional healing from institutional trauma. And so my experience of this workshop and being a seed grantee is not boiled down to probably all of what was written in the proposal, but is very much the experience of what Anna and Michelle and other presenters have brought that has given a way for me to visualize what I thought was impossible, and that's experiencing institutional healing in an academic setting. So I offer those two things for people to think about as what to fund and what to invest energy into advocating for.
Can I reflect on your very beautiful comments? First of all, thank you for the compliment, I think, the first part. I like being like a disruptor troublemaker person, Dean. Like I'm the one who goes to meetings and I say things and people put their heads down like, oh, Halkitis is going to say something again. But I think the second point, I want to just take it off on a tangent. Part of the healing is also being able to examine very critically, openly, and without fear of judgment, the policies and procedures that have been in place in higher education institutions for decades. That is the perpetuation to me of the pain that continues to be experienced in my own faculty, and I know faculty at other institutions. So I see it as one part, this whole the event here and the work we're doing here about healing, but at the same time, pushing back. Because if we don't push back on those things, we're going to continue to need to heal.
Before we jump to the next comment, for those who are joining us online on the live stream, we're about to wrap up our conversation. I'm just setting it up for those of us who are in the room as we move into clusters. Your aim here, as I said before, we're not trying to get at all the answers. What our aim right now is to generate as many of the questions as possible, so we're having kind of the richest conversation, and we're going to break out into separate clusters to allow you to dive further. So don't worry if you're like, I didn't get all the ideas out, they're not fully formed. You've got more time. So that's my plug for us to continue to extend this. And I'm going to toss a question in, which is about where you began, which is we started on individuals, and there's been too much emphasis on individuals. And we've been at separate tables having this conversation. You offered us another vision, right? And so, but you grounded it in public health. What would you say to fields broadly in an interdisciplinary sense of what it means for us to move together beyond individuals?
As people in this room, as a university,
as people shaping science, right?
Yeah, I mean, I think it means breaking down the silos that exist between our disciplines. Like, do you know we have an MSW MPH? Do you know that? We have one. Our schools have one. Okay, good. So, like, breaking down those silos, learning to use each other's vocabulary, right? So that the psychologists aren't using one set of words, the sociologists another set of words. My favorite story is from going to public health school. I went to public health school later in life because I knew in order to become a dean, I had to have the letters after my name. Whatever. It didn't matter. I was doing HIV work for 20 years. I still had the letters after my name. And I remember taking my class, one of my biostats class or my epi classes, and the teacher saying, that's effect modification. And I said, you mean interaction? And moderation. And it was like the word, we use all these different words. So part of the coming together is developing, I think, a common language across our disciplines to talk about these things. Because the psychologists are saying it one way, the medical people are saying it another way, the sociologists are saying it another way, the nurses are saying it another way. Unless we say it collectively, we're not going to move together. That's what I think it is.
Awesome, thank you. Hi, yeah, my question was actually along these lines too. So on one hand, you said that we need to be more focused on ameliorative solutions versus just diagnostic processes, like diagnostic projects, and we need to think, where do we go from here?
Mm-hmm.
On the other hand, we need to be attentive to structural forces and root causes. And I liked your discussion of segregation because as a root cause and racism beyond that. But I just wonder how this sort of squares with our silos working within health, because the solutions are going to be so much bigger than health. And suddenly we're talking about reparations, as Maxine said, or we're talking about how to fundamentally reallocate resources. And I just wonder about those explosive ameliorative solutions given, on one hand, like our training, on the other hand, the pressures of our discipline and how our journals are structured, and also the difficulty of doing interdisciplinary work where, you have someone who is writing on reparations and we're going to come together and do bioethics about this, responding to health disparities related to communicable disease. I just don't really see space for that in some ways, that explosive project, and I think we need to make it, right? So I wonder what you think about, how we bring together the root causes and the ameliorative things given our current silos.
Well, first of all, I think we try to find journals that are open to this idea that there are these cross-disciplinary activities that go on and the ways of doing work. I will do a pitch for. We have 2 journals. In my spare time, I edit 2 journals. On Sunday nights, while I'm watching Stranger Things, there's a journal called Behavioral Medicine, which Carolyn and others are part of, which is very much looking for that kind of thinking. And then a couple of years ago, sitting in, I don't know where I was sitting, on my couch, I was thinking, why are there no journals out there that bring together this interdisciplinary LGBTQ work, right? There's humanities work, and there's a social work. So we created a journal together for that. So there are increasing spaces out there intellectually that are looking for these things. I think the other thing that I really raised today, that urban public health picture that I showed at the end, which means having meetings and having sessions and having discussions that don't only include us. I would love, Frank Pallone and Governor Murphy and other folks from the government to be here right now. I would love the people from Audible and Amazon to be here right now, right? I would love the folks from the Department of Health to be here, because I think we talk to each other, but we need to talk to them, because together we can make the change. I don't think otherwise it's going to happen, right? And look, I go back to what I was saying to my colleague here from social work, which is we have to think about the policies that are at institutions of higher education and what we value. I say this all the time to my faculty, and I feel bad when I say it because I'm a tenured professor, right? But for every 7 people who read one of my articles, which are good, I guess, 700,000 read my op-ed. And you're trying to tell me that doesn't have more impact than my article? Because the op-ed is based on the article, except it's written for people to improve their lives, right? So it's pushing back internally, but also pushing back in our disciplines to break down the boundaries and thinking outside of academia, because the people outside academia understand things the way we don't understand things always. We're stuck in these institutions that have hundreds of years of history that do things, that still use fax machines, right? And the rest of the world has moved on. Those folks, you know what I'm saying, right? It's what do you mean fax? Where's that? Those folks could actually help us advance ourselves, because there are some really amazing procedures, policy systems in these effective businesses that we could use to infuse an energy into higher education that I actually think we're lacking, but also a new generation of students wants.
Yeah, so I have a thought. Is this on? I have a thought about, it links to what Perry just said, but it's been linking to this discussion about amelioration. We were talking about this a little bit at lunch. The word reparations, the word abolitionism, right? These large ameliorative solutions. I don't believe everybody in this room means the same thing by those words, right? I think one of the challenges for us as academics is we always go big. So that's why it relates to where you ended, because we think the problem is that we're not talking abolition, right? But I'm not so sure that we all here would even say the same thing about when you were talking about reparation, you went in the direction of healing and mental health. There's a lot of, social theorists who are talking about reparations. That's not what they're talking about, right? So I'm continuing to push a sense that's developing for me over the day that we have to start, it goes back to Derek's question about, are we setting our bars too high? And do we need to think as researchers? And by that, I don't mean that our goals and our ambitions are wrong. I mean, what is the language that we are using to talk about these things? And if we are talking to each other and we are only talking to each other, then we are not intervening in the problem. Right? So when you talk about a 70-person read article that can develop a massively complex schema for ameliorative solutions versus a 700,000 blog that makes one intervention, just takes one little piece of something, tells a personal story about healing, whatever, but you know why you're doing it. You know there's a whole reparations framework behind why you're writing that story, but it has a different audience, right? I feel like, and humanists certainly suffer from this, because we are probably, of all the areas, the ones who talk the most just to each other. But I guess I just feel like as progressive scholars, we even have to push some of these dichotomies we've set up for ourselves about, are we reformist versus revolutionary? It's all still at a scale that is not it might be translating across academic fields, but it is not translating across social levels. And we want our research to start moving. So that's something I wanted to insert into how we're thinking about this.
Thank you. I've got one more question, one more comment.
So good.
Thanks. And then while you're making your way there, I'm like, was it two? Okay, yeah, go for it. Okay, perfect. Those are my last two.
Can't make a comment.
Because we're gonna go from there to our break, and then to clusters. Go ahead.
So
wait, one more thing. Can I put them together in the way that we did the last one? So both of you make your comments, and then Perry will respond.
Good.
Thank you.
Okay. You made a small comment at the end about doing things like focusing on helping somebody write their CV as an intervention that would actually have implications for health. One of the conversations we had yesterday was, is it necessary to measure health outcomes if we're going to fund an intervention that we know is going to have health implications, and that it would downstream have it, but is not necessarily going to immediately lead to those health outcomes, how should we think about that as a public health intervention? So whether it's some kind of economic change, whether it's investment in a community, that you're not necessarily in a 5-year grant cycle going to see, but how do you, as I guess a dean, as a leader, think about those kinds of interventions as we think about public health?
Absolutely. Yeah, we're going to get both comments on the table. Yeah, go ahead, Ms. Dean, right there.
I'm not sure I had my hand.
Did you? Okay, then I had Allie in the back. And you didn't. I'm happy to pass it on.
But I'll make a quick. I'll take it. Yeah. This is just piggybacking off of what Michelle said. So we're attempting to advance a research agenda that disrupts, fundamental form of oppression. I'm in political science, and interestingly and ironically, you can't get a more apolitical discipline. So with respect to what Michelle is saying, and this is sort of my own thoughts and evolutions, I've continued to advance a research agenda, but I've spent a lot of time in extracurricular political organizing because I'm not always sure that the academics that I work with and the fields that I work with are always oriented toward the type of intervention that we want to do. Michelle, for precisely the reason you're naming, that we're in conversation with each other, but in terms of advancing a progressive objective, that's not necessarily, actually historically, it's not led by academics principally. So that's
Can I tap into to just comment on what Derek said? Because by the way, just a shout out to Derek. I actually had the pleasure of working with Derek on this really great report we put together from American Psychological Association on masculinity in racial and ethnic minority men and in LGBT and in gay men. And if you, it's the APA. It's a really cool report. Wisdom Powell led us through it. We had a lot of fun. It was and Stephanie. Yeah, but I think. Derek, I think here's the issue. Here's how I think about it, right? So on the one hand, I have this job every single day, which is to get my faculty tenure and promoted, right? And I know that to do that, the game they have to play, and I call it a game they have to play right now with the way the funding structure exists. At the same time, I know that I'm pushing back by trying to provide resources and money within my own institution and through projects like this to do that kind of work, because I think that's the work that's really meaningful. So my response to you is, find ways to fund it from non-traditional mechanisms, and two, at the same time, continue to push back on institutions like the NIH and the kind of work that they're funding. And they're open to those conversations. It's going to take a long time to change. But if you can give $10,000, $20,000, go and do I remember early days of AIDS, cooking for people who are living with HIV was one of the most effective interventions in keeping people socially and emotionally happy. Right? Would the NIH fund that? No. We'll get there at some point. We're not there now.
So last comment on the table, and then we'll come back. Go for it.
So I'll hit it kind of quick. So I've always had a problem with the way that the term segregation is used, and particularly how it's measured, but it really is how it's used. And I think, unfortunately, public health is like the primary culprit. and because they're so strong in creating these conversations, the impact is proliferating. But the question is the difference between systemic and system. So systemic, semantically, Webster says it is a characteristic of a system. But systemic racism also exists as its own thing. And the example of that is when you actually look at the history of segregation on law, it's not just a person lives in a place and doesn't live in a place. The Schelling model basically says we're going to move people here and in here, and the end of it is they're going to have contact. And we've spent 50 years trying to measure that, when in fact, if you look at segregation itself, it's how people use power to change the life opportunities of people. And the reality is we don't measure the how. The how is, yes, everybody it's people, there's a percent of people who own a home. Yep. How do you get the house, though? What down payment did they use? Which loan officers? How many applications did they put out? How much money, wealth in homeownership was distributed? Well, it wasn't. A person only has one aspect of that. So it's not. I like people. I like population, but you have to have power, and it can't be ideological, and it can't be conceptual, and it can't be. I think there's power. You actually have to measure it, and then you have to define it, and then you have to act on it, and we act on it without specifying it in those early ways. And this is my critique of public health. All right, there's another one. The reason why it shows up is because this guy says, well, sociologists never think about individuals and behaviors. And all the scholars of race, then he said this thing. I'm like, so you dismiss 60, this is 1969, you dismiss almost 70 years of what really is the Du Boisian school of sociology, where the papers were actually on file. And because when he looked in the library at Harvard, he didn't find anything, then wait a minute, no one did it. And if that's not power, I don't know what else is.
Right.
So, listen.
Amazing.
Yes. And why this room is here, right? This is the purpose of this room. So let me set up what your clusters are going to be before we come back, because we're not coming back to this room. So I want to set up the rest of the day. So again, the goal of this conversation, and y'all have been wonderful, exceeded our ambitions for what this day would be, was to set up a thought-provoking prompt and conversation. Thank you. Perry, can I just do that before we move on?
Thank you, guys.
Just exceptional. But the aim of all of this is kind of developing a research agenda, a talk back. Again, seeing this as a beginning, not an end. And so you're going back into your clusters. Yesterday was kind of an orienting conversation to them and each other and to the goals. Your aim was to kind of listen to all of this today and go back to that cluster conversation, because now you have a different lens and frame to continue the conversation, and you can have more voices around a table of 8 than you can around a group of 3. Okay, so that's your next step. We're going to be in clusters till about 4 o'clock. So you have a break. You're going to go out, turn left. We'll be outside directing you. Each cluster is in a different room. So you'll have room and space for conversation. Your aim in that conversation is to continue to grapple. The steering committee lead, each conversation has one, is to kind of build on the themes and conversation. So again, this is not the end of a conversation, we're just switching rooms, okay? And then the last global instruction for you, the shuttle, it will be downstairs at 4:15. And so again, your aim as your cluster conversation is gonna wrap around 4. You have time for a bathroom break, that sort of thing, but downstairs in the lobby at 4:15, okay?
4:15.
Yeah, if you have your car, you're good. But for those, many of you will be taking the shuttle with us. The shuttle will be downstairs in the lobby at 4:15.
Where am I going?
Rutgers Club. That's where the afternoon talk will be.
Okay.
All right, but right now, out to your left, the same way where there's the restrooms. Yeah, I'll show you. Right, so right out to the left is a break. So your aim should be to get to your cluster conversation room around 2:30. So take roughly 10 minutes, bathroom, coffee. 2:30, we're gonna aim to start conversations in cluster rooms. Thank y'all.